Roll call. During the meeting, I'll ask the commissioners and presenters to identify themselves before speaking, so the commissioners and members of the public will know who is talking and will have the same knowledge as those of us who hear in room 100. Commissioners are unmuted and may speak. Public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask that commissioners and presenters mute their electronic devices when they're not speaking. I would also like to ask commissioners attending remotely to avoid putting substantive comments in the chat, as it can be difficult for those of us in the room to see the comments. MACC posts documents that will be acted on or discussed at least a day in advance, so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and our various social media channels. And I would add for the commissioners online, you don't always show up at the top of the video. We only see a few. So if you have a question and your hand is up and it's been a while, please just say something. And I try to make sure I call on everyone, but I can't always see everybody. I'll now call the roll. Commissioner Bhandari.
Here.
Welcome. Commissioner Blake.
Here.
Welcome. Commissioner Boyle.
Here.
Commissioner Bazinski.
Here.
Welcome.
Thank you.
Commissioner Cheatham. Commissioner Douglas.
Here.
Welcome. Commissioner Gilroyd.
Here.
Commissioner Gilmore. Her hand went up. Oh, okay. Welcome. Commissioner Jensen.
Present.
Commissioner Ojikutu. Commissioner Spinner.
Here.
Commissioner Stratton Duncan.
Here.
Welcome. Commissioner Wang.
Here, and may I say, I love the beard, Chairman.
Thank you. In case this commissioner thing doesn't work out, I can get a job at the. Commissioner Wood.
Commissioner Wood is not able to.
Thank you. Have a quorum. That will turn to agenda item number 1. Included in your packets are copies of the minutes from the November 16th, 2023 public meeting of the commission that took place in person and by video conference. I'll entertain a motion to approve the minutes of the November 16th, 2023 meeting. Do I have a motion? Commissioner Boyle, do I have a second? Commissioner Douglas? All in favor? Are there any opposed? Minutes are approved. Agenda item 2 is the update of activities. Commissioners, you've received the written updates from our centers. Do you have any questions on the written updates? No questions. Well, there, no questions. So, Ben, do you have any additional updates that you wanted to provide?
Thank you, Chairman. We have a rather lengthy agenda, so I'm going to be pretty brief. But I wanted to call out to the commission some of the fine work that's been done by the staff. This year, the legislature was very generous in its assignments to the commission. I wanted to note that as a result of this meeting, should the commission approve, we'll be sending 4 mandate studies. That's work that has historically been something the commission has examined. And it looks like mandates are back on the legislative agenda in terms of suggestions and ideas that stakeholders have for expanding what must be covered in an insurance product. We'll get more into that during those presentations, but our common admonition is mandates by themselves don't typically amount to a significant increase in healthcare premiums, but viewed cumulatively, they do. We will be issuing a cumulative report on the impact of all mandates later this spring. That is something the legislature also asked for. That's going to be delivered at our March meeting. We'll also be, you'll be hearing about the nursing home acquisition report today. That's something that I think we're going to see legislation on during the session. So Stacy and Jean Marie will be presenting the recommendations today. We'll also hear from Ken on the report on the fully insured, value-based, insurance products. That's the result of a legislation passed in 2022, also sometimes called the Care First legislation, which allowed two-sided risk products to be offered in the Maryland fully insured market for the first time. The first report is going to be a baseline report, kind of give us a picture of where things are. And that too is a topic that generates ongoing discussion in the legislature. I don't anticipate new legislation specifically there this year. Previously, we had submitted to the General Assembly our recommendations on coverage of interstate telehealth. You've heard those meetings or presentations earlier this year, as well as a palliative care report that the Commission presented in October and has been submitted to the legislature as well. There's still more in January. You're going to also get several reports that are due, including oversight of small assisted living centers and recommendations on the Commission on trauma funding. That's a core responsibility of the Commission, and we will have recommendations to put forward through that Commission on how the trauma fund and funding for trauma providers in general might be changed. Lastly, we are working with the groups from the department on a study on pediatric dental. I think some of you know that's been a major challenge in the state, dating back almost more than a decade now. And we're to come up with recommendations on how to make sure that particularly the ability of pediatric dentists to access operating rooms, either in hospitals or in ambulatory care centers, can be reinforced or guaranteed. We're still a little bit unclear about the volume of pediatric dental services that need to be provided in ORs. Is that a result of the pandemic and there was a lot of care that was deferred, or is this an ongoing challenge where how we approach that, I think, is very much dependent on how you see the problem. Is it long-term, or is it something that has surged and can be eventually resolved as we get more into the traditional way in which healthcare has been delivered? We're operating with the department, particularly the Medicaid administration, in putting that study together. But it will be a topic in the legislature on Wednesday of this week. Along with the Medicaid administration and the Deputy Secretary for Public Health, presented on our steps going forward. This is a pet issue of the chair of the House Government Operations, Health and Government Operations Committee, and I don't think she's lost sight of it and will be aware of that this is a major challenge. Lastly, in terms of behavioral health, there was a new commission whose duration is 2 years was formed in June. That commission is to look at ways to provide appropriate, accessible, and comprehensive behavioral health services to individuals across Maryland, regardless of what payer source they are accessing. And 4 specific subgroups or work groups have been formed, including one that focuses on behavioral health for the geriatric population. There is a second work group that focuses on youth. A third focuses on individuals leaving the criminal justice system, and a fourth is on workforce issues and reimbursement. That coincides with actually studies that the commission has also been directed to conduct in workforce as well as payment adequacy for behavioral health services. So we're going to be working very closely with that commission, the staff, and certainly if any commissioners want to participate on this broader work group, on the broader work groups that are coming out of this commission, please let me know and I'll direct you to the appropriate people. But a lot of momentum on coverage of behavioral health services, significant interest in expanding access across the entire spectrum of care, community-based care, as well as services as well. So behavioral health will remain an important issue. Lastly, I mentioned the AHEAD model, which I have to always read it, what it actually means, which is states advancing all payer equity approaches and development. That model, which has been rolled out by CMS last month after quite a bit of advertisement. The state has committed informally at this point to compete for one of the early awards. Stay tuned on that. We realized that the Healthcare Commission's work group on primary care investment, which has been in place for about a year, will have a key role to play. And we met last week with representatives from the department as well as HSCRC to be sure that they were fully engaged in the key role that MHCC had played in setting investment targets for primary care. You heard David Sharp present the findings from that report earlier this fall. I think we're well situated, both as a state to compete and for Maryland Healthcare Commission to contribute to this model development. And we'll keep you all informed on opportunities to participate with the planning that goes forward. That's all I have for today, but happy to answer questions.
It would be good, as we got deeper into the model to get, it's almost like a list, an initial list of things we have to figure out, right? Like to make it work. Because I'm sure that there's sort of planning and programs and things like that. At a high level, we could probably cover briefly, like these are the pieces we have to solve for.
Absolutely. We'll look at early next year. I'm making that available as to make sure commissioners are fully aware of what the options are. Clearly, the biggest, I think, concern is an operational concern, which is the healthcare, the hospital payment system in Maryland has been controlled by the state government for decades. Should we go into the AHEAD model, it would seem to me, although representatives of CMS say states will have a lot of control, this new model would be one that would be implemented by multiple states, and federal government would have a much greater role in dictating that. So I think hospitals in particular have gotten used to having regulators close by and also able to advocate for both this body and HSCRC next door. Should these models be adopted, I think that is one concern hospitals voice about would we have to go all the way down to Security Boulevard to make our appeals, and they would be lumped in with appeals from other states, which does connote some risk on the part of hospitals who have made enormous investments in total cost of care model already. What's reassuring is CMS has said, the model for the AHEAD model is what's being done in Maryland and Vermont. I'm not sure that's complete reassurance to the hospitals, but it does indicate that things may be very much mirrored after what's been accomplished already in Maryland. But I think clearly that fact that Maryland government is not going to be as direct control of the model as they have been historically is a matter of some concern.
What's the acronym stand for again?
It stands for Advancing All Payer Health Equity Approaches and Development.
That's 2 A's.
Advancing all payer health equity approaches.
And development. As a matter of fact, we'll send out the solicitation, not that I want to add any more to your vacation reading time, but make sure everyone just has a chance to look at it.
And I believe Melanie Cavalieri has a new staff person to introduce.
So, good afternoon, Chair Sargent, Commissioners. So it's my pleasure to introduce our newest colleague in the Center for Health Information Technology and Innovative Care Delivery, Ms. Carmen Pendleton. Carmen will be working as a program manager in the Innovative Care Delivery Division. She's going to be focused on value-based care delivery initiatives and advancing the clinician's use of health IT. Carmen has a Master's of Science in Clinical Psychology and is pursuing a Doctor of Philosophy in Counselor Education. So prior to joining MHCC, Carmen worked as a Senior Clinical Quality Analyst at Optum. So please join me in welcoming her to MHCC.
Welcome. Joining a good team. Good to have you. Hey, agenda item number 3, onto the actuals. This Luminous Health Doctors Community Medical Center obstetrics program.
Mr. Chairman, I would like to recuse from this one.
Thank you, Commissioner. You can watch us on TV, and as soon as we do the vote, come on back in. Luminous Health Doctors Community Medical Center proposes to build a new acute care pavilion to house a 21-bed obstetrics unit at the hospital located in Prince George's County, Maryland. Jean Marie Gowell, acting CON chief, will present the recommendation.
Good afternoon, Commissioners. Luminous Health Doctors Community Medical Center, Inc., or Doctors, is a nonprofit acute care hospital in Lanham, Maryland. The hospital is seeking certificate of need approval for a level 2 21-bed obstetrics program that will be housed in a new acute care pavilion. At the time of the application, Doctors had 210 licensed acute care beds. The proposed project consists of 2 main components, a new obstetrics program and a new acute care patient tower. The new obstetrics program will increase the current bed capacity in Prince George's County from only 34 obstetric beds to 55 obstetric beds. Prince George's County is the second most populous county in the state with the second highest birth rate, and yet 82% of obstetrics patients are going outside of the county for their care. The increase in bed capacity will improve maternal infant outcomes, such as low use of prenatal care, high rate of comorbidities, a higher percent of low birth weight infants, and higher infant mortality rate. These issues, excuse me, these issues impact Hispanic and non-Hispanic Black women at a higher percentage than non-Hispanic white women, causing a disparity among groups. In addition, Prince George's County only has 73% of the obstetrics providers that it needs, and this new program, through its use of a laborist model, will help attract obstetrics providers to the county. The new tower will allow for more room for support services, such as the lab, pharmacy, imaging, radiology, sterile processing, pre and post-op, and nutrition services. Surgical services will also move into the new tower from the main hospital, and will make 2 of its 12 multi-use operating rooms into C-section operating rooms. The project will include 3,952 square feet of new construction and renovation. The estimated total cost of the project is $299 million. The applicant anticipates funding the project with $33.6 million in cash reserves, $5 million in philanthropic support, $152.8 million in interest income from bonds, and $95 million from the state of Maryland. Based on the review of the proposed project's compliance with the applicable standards in the state health plan, staff concludes that the project complies, is needed, is a cost-effective approach to meeting the objectives, is viable, and will have an impact that is positive. The conditions of the CON are as follows. The first 2 are standard conditions. The first is Doctors shall close its obstetrics program if it fails to meet the minimum annual volume requirements of 1,000 obstetrics discharges annually for any 24 consecutive month period. Number 2, Doctors shall continue to provide a patient with an estimate of out-of-pocket charges prior to arrival for surgery. And the third condition, before changing the funding mechanisms of the project, the applicant must submit a project change. Joining us from Doctors today is Deneen Richmond, the president of Doctors Hospital, Rick Berinsky, Luminous Health Vice President of Financial Planning, Luke Klopp, Luminous Health Director of Capital Projects, Marguerite Crandall, Luminous Health Manager of Business Development, Marta Harding, Esquire, Jessica Farrar, Vice President of Strategic Planning, Charlene Harrison, Vice President of the Women and Children's Service Line, and 2 administrative fellows, Elisa Raju and Venchi Celestin. Thank you.
So, I did have a question. What was the laborist model?
Right, so a laborist model, it's very similar to a hospitalist type model where there'll be a laborist there at the hospital to do the deliveries, and that'll allow the idea is that it will allow the other physician to concentrate on the community practices, and then they are there at the hospital to do the delivering of the babies.
So the laborist, it's a physician called the laborist.
Yes.
Got it.
Yeah.
For some reason that didn't click when you said it.
Mhm.
Commissioner Blake?
Thank you for your presentation. You had mentioned stats around African-American women and Latino women and having a program that's focused on improving their health outcomes. Could you talk a little bit more about the recruitment of diverse staff being a part of that program in order to improve those outcomes?
Sure. I think we have would you guys like to come and talk about that from the hospital?
Hi, Denise Richmond. I'm the president at South Doctors Community Medical Center, and thanks for having us here today, considering our certificate of need. So I would say that we have been very focused on having our workforce be reflective of the community, if I understood your question correctly. Currently, we have over 80% of our employees, and this includes our physicians, actually are Prince George's County residents. And we actually match and or exceed the county demographics when we look at our workforce demographics, race and gender. The one area where we're continuing our recruitment efforts is really around hiring more bilingual staff, because that is one of the opportunities that we identified. But the race ethnicity breakdown of the rest of our workforce population is very reflective of the county. Luminous Health has been very focused on workforce diversity now for a number of years. And so we're very pleased with what we've been able to achieve.
When you say bilingual staff, are you
Particularly Spanish.
particularly
speaking.
Spanish? Okay.
Yes. That's an ongoing focus for us.
And is that staff across the board from administrative all the way up to healthcare providers?
Yes, including myself.
Okay.
So I would say it goes all the way through down to frontline workers, to our physician staff. So for example, one of our primary OBGYNs that we've already hired that is doing her GYN surgery at Doctors Now, and pending approval and having these services available would bring her OB business there as well, is Dr. Jonelle Samuel. She is a Black female obstetrician who actually grew up in Prince George's County. So she's very familiar with the patient population and considers it her community, as I do as well. I am a Prince Georgian, lifelong Prince Georgian.
I have a couple of questions. One, back to the laborist model. So you said that's when the provider is available to deliver the baby once the mother presents. So are these providers also connected to the mom during their prenatal care? Or what's the connection there between the provider delivering the baby, the OB, and their prenatal care?
If I understand correctly, correct me if I'm wrong, but the OB in the community would be the one working with the mother on the prenatal care, and then the hospitalist would be focused on the delivery at the hospital.
Okay, but the mom would have interaction with the laborist prior to giving birth.
Yes, and then we have Charlene, our Vice President for the Women's Service Line. So if she may be able to elaborate even more than I will. So if we think about it today, when many people come into the hospital, their primary care physician, has been providing them care in the community. And then a hospitalist, and I think you used that example, typically takes over their care in the hospital. We do believe that it is important to have that continuity of care. So we do encourage our patients who are planning to deliver to have visits group visits and individual tours and other things like that, so that they are familiar with what to expect when they actually are in labor and come to the hospital. Charlene, is there anything you'd like to add to that?
So, good afternoon. So Charlene Harrison, VP of Women's and Children's. So yeah, one of the other things sort of with this laborist model is that it ensures that the physician is always in-house and they're not really splitting their time between being in the practice and running over to the hospital. So they are there at all times. And so that sort of helps us ensure good, strong workforce from our providers as well. And then the other connection piece for patients as they go from ambulatory to inpatient care is the fact that we have doulas that spend a portion of their time with the patient in the prenatal care period. And then they also accompany the patient to the inpatient unit during labor as well. So patients sort of have that well-rounded care. And then we use one electronic medical record at the hospital and in our ambulatory practices as well. So that regardless of the provider seeing the patient in ambulatory or in the hospital has full access to their record with their entire prenatal care period and their full medical history.
Thank you. And one more question. You mentioned that you were going to have an increase in the number of C-section rooms available. What strategies are going to be put in place to try to mitigate women having to have a C-section? Because I know a lot of Black women typically are forced in a C-section when that's not part of their birthing plan, for example.
So we are participating already as a system in a number of initiatives across the state, including the MD Mom, the health equity, the birth health equity program, and others. We also have had through Dr. Monica Jones, who's our Women's and Children's Medical Chair, a huge improvement effort around decreasing MTSV C-sections among Black moms. So the statistics that I'm sharing right now are related to Anne Arundel Medical Center, which is our sister hospital and the second largest birthing hospital in the state of Maryland. And we've made significant progress because of the very sobering statistics that you're referencing. And so we do things throughout the prenatal period, such as centering programs that have women having group visits, learning how to advocate and speak up for themselves and being educated about what to expect and planning out their birth program that they would like to see, recognizing that if there's clinical complications, we want them to be well aware that, you know, there are some circumstances where a C-section might be appropriate. So we want to make sure they really have that well-rounded health literacy so that they can advocate for themselves, but as well as understand when there's clinical issues that might lead to certain decisions. I'll turn it over to Charlene to see if there's, and you mentioned the doulas already as well. And so I think the doulas are also a huge advocate for the patients. And we've also done a lot of training, not just with our women's and children's staff, but with all of our Luminous Health employees around implicit bias, listening, you know, to our patients, providing patient-centered, culturally competent care. So that's something that has been a huge focus at Luminous Health that we believe helps to mitigate and eliminate some of the biases that can happen that lead to women having a C-section when it's not warranted. Anything else you would like to add?
Yes, so one of the other initiatives that we are focused on, and this includes our nursing staff all the way through our provider staff and our midwives, is a class called Spinning Babies. And what that really is, it is training for care providers to go through that helps sort of understand the physiological positions that you can put a mom in that really ensure, right, that you don't end up at a C-section. So it's upright birthing positions and those types of things as well. And that's another way that we're sort of working to make sure that, you know, C-sections are minimized.
One more question. How many births are you anticipating? Because CON says they have to meet the minimum annual volume of 1,000 births.
So with the rooms that we, in the space that we're allocating to this program and the staff that we're hiring, our projection, and this is a little over 2,000 births, so about 2,300 births a year is our target. We know we won't be there on day one, but I would say that we really have no concerns about meeting the minimum of the 1,000 because in fact, we're planning for significantly more births than that.
Emery, can you explain the reason for the 1,000 threshold?
Oh, the 1,000. That is a standard in the state health plan. Here it is. Have a lot of state plans.
It sounds like you don't plan to be close to it, but I thought it might be
Yeah,
worthwhile
and I
for the
think
commissioners
the
just to
point
explain
is
why
that
we have
do-
it.
If we typically do set volume thresholds on different service lines as they're established, and it's a rule of thumb, not anything that I necessarily is scientifically anchored, but I think we generally think a well-functioning obstetrics program should shoot to deliver about 1,000 babies per year. That keeps the staff familiar with the challenges. And by staff, I mean not only physicians, but the nursing staff and others that are engaged in treating the mother and the I would not expect this would be a significant challenge once you get fully operational. Keep in mind that when we do have CONs, there are opportunities to seek interested party status. In this particular case, no health system or hospital did so. Holy Cross, which is one of the major receivers of mothers from Prince George's County, did not object. And they would potentially be an organization that might be affected somewhat. They apparently did not think this was going to have a significant impact on them. And also want to emphasize that some of the patients that will be delivered, should you opt to award the CON, are actually patients that are now treated at Luminous in Anne Arundel, and they would be brought back into the county for care. One thing we heard repeatedly throughout the pandemic is people want care close to where they live. I think this is well reflective of that.
Do you have a sense of, so 82% of babies are being delivered currently outside of Prince George's County, right? Do you have a sense just roughly where those 82% are going?
I know that Washington DC is about 14%. And then the rest would be other, I guess would be
Montgomery County and Anne Arundel County
yeah.
largely. So you, as Mr. Stefan referenced, Holy Cross, and then our own system hospital, Anne Arundel Medical Center.
And not many then going into the city.
I think 14% or so is, I believe, and largely that's at Washington Hospital Center.
No, I'm in Baltimore City.
Oh, Baltimore City, no.
Right,
no,
right,
sir.
right.
No, sir.
And so nobody was objecting. They were all right with you taking it.
Yeah, no.
Yeah.
They aren't going quite that far.
Thank you. Great presentation here. I was taken with the comment that just building this would attract more OB care to the county. Is that an assumption, or is there an active recruitment plan to do so?
We actually have an active recruitment plan, which is already underway. So prior to bringing obstetrics pending approval to Prince George's County at our Lanham campus, one of our unmet needs also in the county has been GYN surgery. So we have already started our recruitment efforts and bringing in OB-GYNs. Right now, they bring their GYN surgical cases to doctors, and they're seeing women in Prince George's County for their prenatal care. We have opened up some new practices as well. However, those deliveries right now are taking place at our sister hospital, Anne Arundel Medical Center. So we have an active plan, and what we've heard as we're going through those recruitment processes, particularly for an OB-GYN, they want their GYN and their OB cases to be, convenient, and they want to treat women. They want from a quality of life to be able to, do everything that they need to do in one facility. And as we've heard from patients repeatedly, they also want to receive their care close to home. So we have an active recruitment plan that's underway, and we'll just accelerate as if we're allowed to move forward with this, and as we get closer to being able to offer actual deliveries at doctors.
Exciting.
Any more questions or shall I call a vote?
Mr. Chairman,
Go ahead.
this is Commissioner Bandari.
Right ahead.
First of all, I want to thank you and taking this step. As already mentioned, Prince George County is the second highest population county, and we have only 2 hospitals compared to Baltimore, where the population is only 600,000 and many more hospitals. So thank you for doing what you're doing for citizens of Prince George County. So I know I practice in Annapolis. I know a lot of patients, they come from Prince George County or other counties to Annapolis. So I want to have a follow-up, maybe in 2 to 3 years. I want to see whether the patients are staying still in PG County Hospital or they're still coming to Anne Arundel County. I think there is some concerns in the population. The care is better in Anne Arundel County and other counties compared to PG County. So we need to fix that. And secondly, one of my other commissioner asked about the workforce. I heard from patients, those who go to hospitals in Prince George County, they have to wait in the waiting area a lot. The reason is staff does not want to work. I'm going to be very, very precisely what patients tell me. So that need to be changed. I need to have some follow-up on that. And the third thing, which I have a question, can somebody explain why these patients are going to Holy Cross Hospital? Because it's a charitable care, because I have friends there also. Most of the patients, those who get care in Holy Cross, either they are undocumented, illegal patients, or they fly from other countries for the care. So is there a good reason why the patients are going? And probably that is not going to get fixed, even if there is a new OB, section in the Doctors Community Hospital.
So I'll take a stab. I am not in a position to comment on which patients are coming to Holy Cross because that's just outside of my purview. Except for one comment I will make is that many of the patients that are currently going, or a subset of the patients that are going to Holy Cross for their deliveries are have Kaiser insurance. We actually are a Kaiser core hospital or premier hospital. They keep changing their terminology. And Kaiser does do some of their deliveries at Anne Arundel Medical Center.
Commissioners,
And of
pleased
course,
to provide a brief overview of the FY 2023 fiscal year.
Somebody needs to.
Richard Proctor, you're on your phone.
No worries. So what I was saying is that we currently are Kaiser Premier Hospital. They do some of their deliveries at Anne Arundel Medical Center. And we would expect and starting those conversations with them when we hopefully would have a program of being able to keep those Prince George's County residents in the county. And so that's a part of our plan as well. You also had asked a question. I may need to ask you to repeat your other 2 questions.
Sure. So
we could take under advisement.
Yeah, I think
Okay.
Dr. Bandari, I think we have to look into the question you raised about undocumented. We do have access to all discharge data from the state, and rather than we have a busy agenda. I think rather than conjecturing, we should come back to you at a future meeting with facts on that.
Thank you.
It'll work. Any last questions, comments before?
Yes, I have a comment. Commissioner Bazinski here. As some of you know, I do provide obstetric care. I'm curious about the minimum number of deliveries. I mean, if it's an underserved population who needs care in their community, why set a lower threshold for the number of deliveries? I mean, maybe I take this a little personally. Our hospital here where I deliver at, we only do about 250 to 300 deliveries a year, and it's a huge asset to our community. So I don't quite understand the rationale for setting a floor threshold. I mean, if doctors wants to have, 12 obstetricians and deliver 1,000 babies or 900 babies a year, if it works for them, it works. But any babies they deliver there in the community by people who are from the community seems to be an asset to the community. So I'm not sure why we need to set that lower threshold there. That's something the commission said, right? That wasn't requested by the doctor's hospital.
Are you referring to the
1,000?
Yes,
Yeah.
she's asking why we need
Why do we need to set it at 1,000? Why do we have to have a floor threshold for a number of deliveries?
Really not sure about.
Did you say earlier that it was in the state health plan?
It's in the state.
So it's required. We don't have a choice.
Then why is?
We make the state health plan, but typically when we're looking at the addition of new services, and recognizing that there are costs with new services, we do set thresholds. I think, when we open this up again, it will be so noted that one commissioner thought 1,000 was too high. I think, I would argue that you do want to set a threshold for services that are expensive to provide, and we want clarity that we expect significant volume. I think in this case, given 82% of the deliveries are occurring outside the county, that there should be, as the program establishes itself, no problems meeting that threshold.
It isn't philosophically what we're doing. It's a certificate of need. So we have to demonstrate some need, and that need would have to be quantified in some fashion.
Thank you. And then I had one other question. The delivery room configuration, I saw it mentioned as 3 antepartum and 18 postpartum. Probably it's a matter of syntax, but is your model like the LDRP, labor delivery recovery postpartum rooms? Or how does the patient flow occur in your 21 beds?
And I'll let you take that. So yes, that is really sort of how things are set up in our labor delivery rooms, is they are LDRPs, right? So that a patient can sort of remain in that room throughout their time with us at the hospital.
Okay, that's a good model. And the dedicated C-section rooms, are they on the same floor as labor and delivery, or does it involve an elevator ride?
No, they are on the same floor.
Excellent.
And is there any charitable care in this one or no?
I'm sorry.
Any charitable care?
Oh, charitable care.
Charitable care?
Yes.
Yes, actually, there, you want to?
Yeah, so I mean, we provide I would have to look up the exact number. I'm sorry, I don't have that off the top of my head right now, but we, considering the demographics of the patient population that we serve, provide significant charitable care. And all of our employed obstetricians, will take the appropriate patients, all except Medicaid, et cetera. So we don't see that as being an issue, particularly in the mail-in payment environment as well.
Right.
So does anybody have any burning questions? Because I feel like I know where the vote's gonna go.
I'm sorry, Chairman. I have one, this is Commissioner Bazinski, one burning question.
Go ahead.
In the report, they discredited hospitals in the area that were not CMS certified birthing friendly hospitals. And, basically they only accounted for obstetrical service provided by hospitals labeled birthing friendly. And I don't know if that just means they have a birthing unit or if there's a higher standard to meet with that. And to me, maintenance of that birthing friendly hospital standard would be a valuable mark of quality, I would think, for this hospital, this program going forward. So I'm just wondering, is that something that this hospital will attempt to achieve or whatnot?
Yeah, that is pretty much a brand new metrics within the last few months on CMS, when you can look up about the birthing friendly hospitals. So I'm sure you guys will be working towards that. I mean, it's based off many metrics that CMS looks at. I'm not sure exactly what they are, but it's a multitude of different metrics. And you can go on the website, and each hospital that has achieved that has its own special logo there. It's actually like a mother holding a child. It looks like a heart on the website. So it's new.
To me, that sounds like a better metric than a floor number of deliveries for we're looking at quality of care. But anyway, my comments are done. Thank you very much.
And look, I think those are comments to take in line when we look at revising that part of the plan. We should always be looking at, are those the best, most modern standards? All right, if there's more comments, I will call a question. Do I have a motion to approve the CON for Luminous Health Doctors Community Medical Center Obstetrics Program in Prince George's County, Maryland?
So moved.
Commissioner Jensen, do I have a second?
Second.
I'll give it, sorry, Commissioner Bazinski was slightly ahead.
Thank you.
Anybody with a further discussion? All in favor?
Aye.
Are there any opposed? Congratulations, you have your CON. Thank you for coming and talking to us today.
Thank you, Chairman, and to all of the commissioners and allowing us to really make some great enhancements to the health of Prince Georgians, and we are very appreciative. Thank you.
Appreciate your presentation and taking on the expansion of this role and this delivery service for that, for your market in Prince George's County for that need. And also in an environment where the malpractice costs are not insignificant and the risk is significant.
Thank you.
I second your comments.
You're not going anywhere.
Not going anywhere.
Agenda number 4. Nursing Home Acquisitions Work Group Report. During the 2023 legislative session, MHCC was asked to conduct a study regarding nursing home acquisitions. The goal was to examine the current role of the Maryland Healthcare Commission in regulating nursing home acquisitions and the impact of acquisitions on the quality of care in nursing homes. The work group was also required to look at 2 areas related to the effect of acquisitions on the quality of care: private equity and rooms with 3 or 4 beds. Stacy Howes, SEAM, Chief of Long-Term Care and Health Plan Quality Initiatives in the Center for Quality Measurement and Reporting, and Jean Marie Gowell, Acting Chief of Certificate of Need in the Center for Healthcare Facilities Planning and Development, served as co-chairs of the work group and will present the recommendations for the work group. Welcome.
Good afternoon, commissioners. Slides.
So, Levon, is there someone?
I can do it. Say slide. Okay, next.
Next slide.
Next slide. Okay.
Hey.
Okay. Well, she left, I wasn't sure.
AI.
All right, so first we'd like to tell you a little bit about House Bill 702 and Senate Bill 509. Next slide, please. This was a legislatively mandated study, and the goal of the work group was to evaluate MHCC's current role in evaluating nursing home acquisitions and the impact on quality of care. Specifically, the work group was asked to evaluate the impact of private equity and multiple bedrooms. Multiple bedrooms are defined as rooms with 3 or 4 beds for this work group. Next slide, please. The bill stated that for every nursing home acquisition, MHCC will compile a report for OHCQ, and the Secretary of Health should take into consideration our findings and recommendations. Our findings should consider a list of quality metrics such as the CMS 5-star rating, inspection reports, and lawsuit findings, among other metrics. Applications for an acquisition must include anyone with an ownership interest and information about whether they can comply with medical care, nursing care, and financial conditions. As a result of MHCC's report, the Secretary of Health could approve, deny, or revoke a nursing home license. In addition to creating these reports, the bill required MHCC to conduct this work group study to examine the impact of acquisitions on nursing home quality, and specifically to examine the role of private equity and 3 and 4 bed rooms. Next slide, please. A little bit about the membership of the work group. Next slide, please. We invited individuals from a wide variety of organizations and varying opinions to participate in this work group. Multiple state agencies are represented, and 3 legislators and 1 commissioner participated and regularly attended. There were representatives from multiple organizations and the nursing home industry, patient rights advocates, AARP, and Alzheimer's Association, among others. Next slide, please. Next slide, please. So first, a few statistics about the current nursing home industry. We currently have 224 nursing homes in Maryland with just under 28,000 certified beds. And nursing homes are at approximately 77% capacity with over 9 million patient days. 62% of nursing homes in Maryland are owned by chains and 2% are hospital-based. 19.3% of residents discharged from the hospital to a nursing home are readmitted to the hospital within 30 days. Next slide, please. There have not been many state initiatives to examine nursing home acquisitions, and over a 5-year period, 1/3 of nursing homes changed ownership, making Maryland 5th in the nation for changes in ownership. OHCQ recently released a change of ownership dashboard, and this does contribute to transparency. And MHCC reports on nursing home acquisitions monthly to this commission. Next slide, please.
In recent years, there have been several federal resources published, such as MedPAC, CMS, GAO, and the White House, where they've analyzed recent growth in private equity in nursing homes. So nationally, 11% of nursing homes were owned by a private equity firm in 2021. Publications I mentioned suggest a lower quality of care post-acquisition. And recently, CMS published a final rule defining private equity and real estate investment trusts and requiring the disclosure of these types of investments. Next slide, please. The work group met six times over the course of 7 months, beginning July 14th. In the first meeting, we discussed the charge for the work group, reviewed current state and federal initiatives, and the Deputy Director of Long-Term Care at the Office of Healthcare Quality presented to the work group about change of ownership process on their end and demonstrated the change of ownership dashboard that I just mentioned a minute ago. Next slide, please. At our second meeting, we had 2 guest speakers. The first was Atul Gupta from the University of Pennsylvania, and he discussed how and why private equity growth has been rapid in the past 10 years. And he also highlighted how many of the outcomes have been negative after acquisition. The second speaker was Shelley Martin from the Office of the Attorney General, Consumer Protection Division. She discussed negative outcomes her office has seen regarding private equity firms in nursing homes. Next slide, please. Our guest speaker at our third meeting was Robert Kramer, who is the founder, chair, and fellow at Nexus Insights. He discussed how the nursing home industry has changed since the pandemic. Yes.
I'm sorry, when you slide back, you're talking about the people presented and they talked about negative outcomes after private equity acquisition. I'm assuming you're talking about quality and patient safety, and you're not talking about economics.
Correct. Yes. Quality of care, negative outcome.
Right.
That would be negative outcomes for the private equity. folks.
Hmm?
They probably weren't looking at negative outcomes for the private equity folks so much as.
Yeah, probably not. And thank you for confirming.
Thank you for that question. So at the third meeting, Robert Kramer discussed how the nursing home industry has changed since the pandemic and what Maryland can do to prevent bad actors. And he discussed how private equity is different from REITs and explained why Maryland has been heavily infiltrated with private equity firms. He urged Maryland to be neutral about private equity and focus more on transparency. Next slide, please. Next slide, please. At the fourth meeting, we discussed options for reducing or eliminating multiple bedrooms and additional options for quality oversight. At the fifth meeting, we presented the first draft of recommendations to the group and received feedback. And then at our final meeting last week, we presented the second draft of recommendations to the group and received additional feedback. And now we would like to share the recommendations and feedback that we received.
Thanks. Next slide, please. Okay, recommendations. Next slide, please. Okay, recommendation number 1. So the first few recommendations all are pre-acquisition Maryland Healthcare Commission responsibilities. So for the first one, the MHCC will have a report called the Report and Recommendation. This report will go to the Office of Healthcare Quality, the Secretary of Health, and will also go to the Office of the Attorney General. And it'll include a summary of findings. And I'm going to go through those on the next slide. The report will include Maryland facilities for operators that are in Maryland. And if the applicant is not an operator in Maryland, will it include from other states? Next slide. This is a list of metrics that will be part of this report. And I do want to mention that as part of the bill that was used for this work group, we've already started to put something similar into place. So we already are writing, as of October 1st, we have already writing our first memos to OHCQ and to the health secretary. So we have started this, just not as many metrics on it. So the metrics will be the most recent CMS 5-star rating. The second one will be the court cases, and we look at those through a variety. We use the PACER website, look at federal false claims acts, etc. The third one will be the OIG exclusions program. The fourth one will be the status or existence of a memorandum of understanding or MOU with Medicaid. The next one will be the percentage who will recommend for our nursing home facility family experience of care survey. The next one will be whether or not the facility has any flags for CMS flags for being a special focus facility or for being having resident abuse at the facility. And then the last one will be any fines or payment denials that'll be reported in.
Can I ask a quick question?
Go ahead, and then I'll ask mine.
Yeah.
Go ahead.
So a quick question is, I understand the recommend and the engagement surveys, but there are a lot of reliable and valid quality of life surveys. Was any of that considered?
Quality of life survey.
They're used by some nursing centers across the country.
Oh, okay. I'm not familiar, but we can definitely look into that as a possible metrics.
Data set, the nursing home minimum data set measures.
Some of them might be included, but there are actually surveys related to quality of life from the perspective of the residents. And families can help fill those out too. And I just feel like there's a body of literature now on quality of life, and we're thinking so much about even the IHI program, what matters to the patient, what matters to the person. So I'm just trying to get at how else do we know about the quality of the care?
Thank you for that.
My question was gonna be, my question is gonna be this, under this recommendation, these are all public sources of information. We don't have any information to, at that point, to look into the deal or find out non-public facts about the deal.
Right, all of these, you can do most of this, all public information that you can access.
Is the reason I'm asking is, with a lot of private equity, one of the biggest drivers of the failure of a business after private equity or cutting back is the amount of debt that they're taking on in order to do the deal, causing them to have to squeeze everything they can out of the business in order to satisfy the extra debt. And it seems to me like the amount of debt that is being taken on in order to do acquisitions might be a leading indicator of future patient dissatisfaction. And I don't know if there's any way for us to look at that, or even figure out how much debt is too much debt, or things like that would be if you're looking for red flags, right? You'd be looking for someone who's taking on a lot of debt to stick a bunch of centers together and then eventually take a public or sell them down the line to a bigger institution.
Good question.
Yeah. What is the plan? It's sort of like the house flippers of the company buying market, right?
Right, so there's gonna be coming up in a separate recommendation, a follow-up report, and we can talk about that, but that kind of gets to what you're speaking about one of the things that we're gonna be looking at.
Was there any talk about a discussion of providing deadlines for the provision of this report in recommendation number 1?
Do you mean how long it will take? Yeah. Okay, so right now we have 30 days. We discussed 60, but landed on 45.
Isn't that later on in the presentation?
It is also later on in the
So-
presentation. And we think that we can get all of this information in 45 days.
Do we knock you off track? Let you proceed.
Okay. Okay. All right, next slide. Okay, the next slide, recommendation number 2, we're still in pre-acquisition responsibilities. This one is something that is actually already in place as well, and that's just that we will continue to provide to our commissioners, the Maryland Healthcare Commissioner update of activities. This is something that's provided monthly, and we will continue to do that.
That's where I come up with all my questions.
Okay, also, next slide, please. And recommendation number 3, also pre-acquisition, this time for the seller, the nursing home that will be selling. So for this one actually came from multiple responses that we had during the work group, that we wanted to have where the notification of residents and their families of the pending acquisition. We wanted to sort of solidify that for transparency. So what we're going to do is add question number 17 to the acquisition form that we have them fill out. And it's going to require that they include the date and method of the notice that was given to the nursing home resident or designee. And it will also be copied the ombudsman, the attorney general as well, so that we make sure that we know that they have been notified of the pending acquisition.
Oh, sorry. Go ahead, Commissioner.
Commissioner Stratton Duncan. So I think it's great that we're putting it in to have the residents notified. I wonder if we may need to drill down on that to make sure that that notification includes the effect on the resident as well as the time frame for these things to happen, so that the resident is not only aware that it will be changing ownership, but also aware how it's going to affect them and when it's going to affect them. So I think it might be a good thing to explore how detailed we are with that notification.
You're here. Agree.
Thank you. Anything else? Okay. All right, next slide. These were some of the comments that were from the work group participants on these particular recommendations that I just went over. I'm not going to read through them, but they're listed here. Many of them had to do with transparency, allowing residents to have enough time to review the acquisition materials, etc. Next slide, please. Okay. Recommendation 4, post-acquisition Maryland Healthcare mission responsibilities. So this one is going to be called the follow-up report. So the nursing home acquisition follow-up report that will happen after the acquisition. And the purpose of this is for us to study trends, us at the commission to study trends so that we can hopefully inform future policy decisions. Following metrics will be included in this report. Next slide. Okay. The first one, the detailed plan and progress towards reduction of multiple bed rooms. That's rooms with more than 2 residents per room. Operating revenues, operating expenses, net income, ratio of total direct care staffing, hours of bedside care, occupancy levels, and hospital admissions and readmissions. Next slide. The information for this report will be from end of year financial statements. We're going to be asking the facilities that have been recently acquired, the new owners, to be reporting to us. We will require that if they do not keep up with their reporting, that they will have to appear before the commission to report on their progress publicly. We do also have the authority to impose monetary fines for non-compliance of reporting. And again, this information will be shared with the Office of Healthcare Quality and the Office of the Attorney General. Next slide. Yes.
So if they do report, but the report's bad, what happens?
Right. So I think our idea is that
Recommendation 5.
Yeah.
Recommendation 5, the commission shall recommend the denial of an acquisition, but this is after acquisition. Right?
Sorry, I should just let you go ahead.
Right. So I think if it's bad, so I think we're going to be looking at the trends for the next 3 years. So my idea is that we would report to the commission, perhaps maybe once a year, an update on all of the acquisitions that have happened that year, so that we can start tracking data points, so that we can really understand how things change after a nursing home is acquired. So, you know, do the staffing levels change and those type of metrics? And I think at this point, we're really focused more on, we almost don't know what we're going to see in those trends, but we're hoping that it'll be able to inform and give more information for us going forward.
But then, well, go ahead, Commissioner Bolle.
I think
I know where you're headed.
following up on what you're saying is then which state agency, is it OHCQ? Which state agency then would be informed and hopefully take some action?
Right, and we're gonna get there in these, we're just ahead of ourselves a couple on the slide, but, so if we could just.
So there is an enforcement provision for a bad report coming up on a,
Right, so right now we have that is sort of with the OHCQ, which is who we're doing the reporting to. But the issue is that if it's on a timeline, so we are working pre-acquisition and then the acquisition occurs. So by the time that gets to OHCQ for licensing, the facility has already been acquired. So we're already at that point beyond the acquisition. So we are looking at whether Maryland Healthcare Commission will have more authority going forward so that we could possibly may in the future be able to stop things earlier.
what I'm looking for clarity on, and perhaps I missed it in future slides, is just this. I don't really want to be in a position where, okay, it's post-acquisition. So we're gonna get these reports for 3 years after the acquisition. The acquisition's done. We get 3 years of reports for a facility that shows that it's doing poorly for 3 years. I'm not gonna feel particularly great as a commissioner going home saying, well, we know they're doing bad. And nothing's gonna happen except it's gonna get aggregated into data that might be used to put some enforcement provisions in place in the future. So it doesn't have to be doesn't have to be us that does any enforcement. Perhaps it's not us, but I would kind of like to see that loop get closed.
Some clarity as to that's within the remit of OHCQ if it is.
Or somebody. I mean, is that,
Sure. So I think that our focus has been on taking some additional control over the process pre-acquisition. Post-acquisition, I think the thought is that these reports would not only be shared with the commission, but be shared with OHCQ for some enforcement action as a result of their responsibility for inspecting the ongoing quality of the facility. They are required today to inspect nursing homes every 15 months as part of CMS regulations. During the pandemic, that fell by the wayside. If you go to our website, you'll see that there's still quite a bit behind. But I think after the acquisition takes place, we're going to have to rely on OHCQ to take action rather than commission. Now, what we do have is the ability to look at a purchaser or a operator when they come forward with another CON, and if their financial reports are derogatory, then I think it gives us additional ample grounds for recommending a denial of the acquisition. But I think post-acquisition, our authority is kind of limited unless we really go to the legislature and say we want to take on roles that OHCQ doesn't want to take on or can't take on.
I'm not suggesting that we need to be the ones that take them out, but I see that OHCQ is part of the work. So is it possible to build into these recommendations something that says if we get bad reports, OHCQ agrees to take them and do something? Or as OHCQ say, we're not going to do that. But seems to me, since they were part of the work group, we could.
And one of the, OHCQ has more than dozen entities they inspect, and the common warning is that we are monstrously understaffed, but we will work with the OHCQ to clarify what they would do with these reports, if anything. And so note that in the.
And we could even suggest that these would help them to focus their limited resources, because if you have limited ability to inspect, and we target people that perhaps were giving us bad reports and needed that inspection. I'm done.
Thank you. So I think I heard you say inspections occur every 15 months where they're supposed to. That's fine. But how often are these data supposed to be reported? Because I thought you said annually, and not even 3 data points is a trend. So how would we be able to get to a place where we know that something's trending in the wrong direction? I mean, they might start out terrible when the acquisition first happens, but be able to pull themselves up. And I don't think statistically we would know it unless the reporting is more often.
Okay. That's a good point. Thank you.
Yeah, I think that on the financial side, it's gonna be hard to rely on trusted financial reports that are not submitted at year end, because that's usually when the threat of either the receiver of that or actually the operator themselves would audit those. But we can look at that, but the financial data gathered intermittent, can be very hard to trust because it's kind of, can be not as carefully assembled as an end of year report, but some of the other quality measures that we're talking about could be gathered more frequently. And, we, as you know, from the 5-star system today, we try to update those whenever there is a update from CMS.
Next slide. Next slide. Okay, recommendations 5 through 7 are statutory changes. For recommendation number 5, the commission shall recommend denial of an acquisition based on quality metrics and other standards as appropriate required in certificate of need reviews to align the CON quality standards with nursing home acquisition regulations. So this would be what we spoke about before, where we would have more say at the time of acquisition, and we would do that based off of how we look at quality in a certificate of need review. So then the work group felt like it made sense to align those two things together.
Oh, go ahead.
My earlier question about the amount of debt, would this be a point at which we might look at the finances of that proposed acquisition also? Because we do look at the finances of a new CON project, and if we don't think that the project is viable, I'm just wondering if that could be built into the standards that we're adopting at that point as well.
I think that's a great idea, Chairman Sargent.
I don't know if to change any of the wording here.
But the whole idea is that this would align closely with the, the standards that we do for a CON. And, this is what I have been pushing for. I think Ben knows. And, given what we've learned about the lack of resources with OHCQ, and then by the time they get it, the acquisition has happened, it seems to me this would be the most logical step to take.
I also strongly support that.
Next slide.
This is a much more fun. You don't realize it, but you're enjoying this much more than if we just sat here and looked.
Okay, this is the one that we already spoke about that you brought up earlier, Commissioner Jensen, about the timing and the 30 days to the 45 days. We did consider 60, we landed on 45. Next slide. Okay, so the next one is about the beds. So for this one, the commission shall expand its authority to require an acquiring entity of a nursing home to eliminate or reduce to the maximum extent possible the number of multiple bedrooms within 3 years of the acquisition date. Next slide. Here are some of the comments that came in through the work group, and I won't read through all of them, so you guys can hear on the slide. Next, yep.
Okay, so I remembered in the comments, somebody talked about a 10% reduction. To me, that feels low. I mean, if you have private equity and they're coming in and they're figuring out a whole new entity or merging of entities, I would imagine they would thinking about all the sequelae and infection prevention and all of those things, that reducing from 3+ beds should be a way higher priority.
You felt like the 10% that was suggested was low.
I do think so.
I would agree with you. It's one reason I didn't I was on this work group and I felt that I didn't speak up on it because I really feel the commission will do the job in pushing this. I mean, it's a priority, but I felt it was low.
So just as a context, where are the three bed or more facilities, where do they predominate jurisdictions? Probably helpful to put that in some context.
We have that information. Hold on.
They are predominantly in Baltimore County, Carroll County, Somerset,
George's
sorry,
and Prince George's.
and I believe Prince George's. Yes, Prince George's and Wacomico.
So there is, I think, to be fair to the input from the stakeholders, that there was quite a bit of pushback from the industry about, not that there was necessarily disagreement, although there were a couple people who did make the case for people liking to be packed into small, 3 and 4 bed.
No, and quite a few people said that.
It's for each of the commissioners to evaluate, but the point they made is that this was taking a property that should either be transitioned or reimbursed. We certainly would not be of the opinion that it should be reimbursed, but it would argue for some transition. We think that moving forward in this at a period of time when occupancy is low might be ideal for reducing these triple and quad bedrooms, because it's a little easier to do it when you have ample capacity as it is. But I think that the industry made the point that many people felt, yes, we endorse this, but it's a little harder to do than simply snapping your fingers. I think that's why we recognize maybe a transition is appropriate, as opposed to, you can't acquire a nursing home that has triple and quad beds, meaning at the time of acquisition, it has to drop to 2 or fewer in order for the acquisition to be authorized. I think we recognize that was maybe a little bit too severe.
And I respect that and agree with it, that at the time of acquisition, we don't have to require nursing homes, but to get from down to 2 beds or less. But I do just again share that with all of the financial problems of hospitals, they've had to reduce to single patient rooms as much as humanly possible. There's very few 2-patient rooms in the state compared to what there were. And here we have allegedly an influx of cash from private equity. That's why these folks can consolidate. And I think the question is, where do you put that money? And it's more of a one-time cost to reconfigure than an ongoing operating expense. And I just, again, support the idea of being a little more aggressive.
My question is about the infection control data. Will that be a part of the follow-up report?
We haven't specifically added that as part of the follow-up report, but we can, if that's a suggestion.
My thought is, as we're talking about the consolidations of rooms, it would be of value to see the infection control data as the follow-up report, as we can just get more information to compare about how successful the consolidation is, and just also similar to what we spoke about earlier, overall, how the nursing home is doing, and that would play a part.
That's a good suggestion. Thank you. Thank you. Okay, last couple of recommendations. Okay, the last few, I believe this is the last slide with recommendations. So the next one is recommendation for the Department of Health. OHCQ shall implement the current statutory requirements set forth in Health General 19-1408 by conducting a full survey within 3 months after the date of transfer. 2, the Office of the Attorney General shall evaluate expanding their authority to play a role in the acquisition process. And then the third one on there is the Office of Long-Term Care Ombudsman shall evaluate expanding their authority to play a role in the acquisition process. Any questions? Okay, and then I believe that's the last slide on recommendations. And then just quickly to review what the next steps are, is to was to be here with you guys today and to get your feedback. And then we have a report that's due on January 2nd. That'll be the next step if you approve everything.
I just want to comment about what a great job Stacy and Jean Marie have done on this. It's been an amazing group to get together. People were very committed on this. And the three state legislatures, attended the meetings, which is quite amazing. But you've done a great job, and you've been open to suggestions and flexible, and I have to commend you.
Thank you for being a part of it.
Thank you.
I felt the same way. Congratulations. It's important work.
Thank you.
So, procedurally, today, we can approve these recommendations as amended, but we haven't yet seen the report. Then how do you suggest we handle the report, which is due by the end of the year?
So, yeah, I think that the commission should vote on the recommendations as modified. And then we should send back to the commission next week, the report. And I think we could approve it through email confirmation. If that passes judgment with the attorneys, I would not want to wait until the middle of January to take action on the report, given we expect there's going to be some legislation in place. Counselors, have you?
It would need to be at some sort of open meeting, so by email, it would need to be open to the public.
Could we schedule a short Zoom meeting? Establish a quorum and just have one vote?
It may be easiest, swiftest that way.
Suggestions? 2 hours. So you go in 2 hours? Yes, sure.
They go work on the report and come back by the end of the meeting and hand it out, and if it's.
I think
I'd like to give the commissioners a chance to read it, but I don't think.
We won't be paying attention to the rest of the meeting.
Already ready.
But why don't we do this?
I have this piece of paper that says page the order, but pay no
We
attention.
can do a quick Zoom meeting.
I'm okay with it.
Yeah, I mean,
If there's things we need to discuss, it'll be important, and if we don't need to discuss anything, it will be short, so
I think
either
that-
way, we win.
So I think today we would take action on approval of the recommendations as amended during the meeting. But with the full release of the report until they have a chance.
Commissioner
Sure.
Sargent, Commissioner Brzezinski here.
Yes, sir, go ahead.
Quick question. I know recently we made some changes to the CON process to streamline it for the applicants and so forth, and to define interested parties more clearly and accurately. Is there any obligation or any attention to that in these recommendations that, if we're requiring more of the companies that are acquiring nursing homes, will we be able to promise them that, a timely review and, a relatively streamlined process? Or is, is it something that they're just going to be at the mercy of, as we figure it out ourselves, we'll get around to, approving their acquisition and so forth?
No, when we put that 45 days, that was based, I can base that off of having done this for several years and the information that we've had to gather in the past versus, what we're having to gather now. So it wasn't just it was, you know, it was an educated, I think that we can do that, and make it a streamlined process for them. The first couple that we've done since it changes since October 1st, even though they were the first ones, they went relatively smoothly. So I think it's just everybody learning the new process, and, you know, we do what we can to help them. And, it's gone relatively smoothly so far.
What's the enforcement mechanism and penalty for us as commissioners if we don't meet the 45-day deadline?
So if
Zoom
we
meetings.
don't meet it, then the acquisition wouldn't go through on time.
Right, so if we're just slow, we could be putting the industry at risk. That doesn't seem like a real business-friendly kind of approach.
Yeah.
So I might, if it might help a little bit, my understanding is that we make these recommendations, we're making them to the legislature as we requested. If we proceed on any of these, we're gonna need some statutes, and then we will have a set of regulations that we can also look at before, like we can address timeliness and integration with our CON reforms and things like that in those regulations. Am I right about that? Like, I just wanna make sure that we will have a chance to get into the weeds before anything gets rolled out. And making sure because I agree with the concern. We don't want to just bog things down for their own sake, but we need to do the review. We need to redo.
We don't want to bog them down here now.
There you go. I'm trying to keep us on track. Yep. I appreciate the engagement though, commissioners. So do I have a motion to approve the recommendations for the nursing home acquisitions work report as amended by our discussion?
So move.
Commissioner Jensen, second.
Second.
Douglas, one. All in favor?
Aye.
Are there any opposed? Great, thank you, Pass.
Thank you.
And item number 5, updated mandated health insurance services evaluation. Health insurance, annual behavioral health wellness visits, required coverage and reimbursement. Article 1501 annotated Code of Maryland requires that the Maryland Healthcare Commission annually assess the medical, social, and financial impact of proposed mandated health insurance services that failed to pass during the preceding legislative session or as requested by a legislator or legislative committee by July 1 of each year. The next 4 agenda items relate to proposed insurance mandates that MHCC was asked to assess. MHCC staff received a formal letter of request from the Senate Finance Committee to evaluate the legislation Senate Bill 108, introduced during the 2023 session of the Maryland General Assembly, but failed to pass. MHCC staff contracted with Axine Health Partners, an actuarial consulting firm, to evaluate SB 108, which would have required health insurance carriers to provide coverage and to reimburse for an annual behavioral health wellness visit on the same basis and at the same rate as an annual wellness visit for somatic health. Representatives from Axine Health Partners presented to the commission at the November meeting were asked to make changes to the report before it was presented for a vote. Kenneth Yates Trotman, the director of the Center for Analysis and Information Systems, will present an update. Cam?
Thank you. Good afternoon. Thank you, Mr. Chair Sargent, and good afternoon, commissioners. I'm here to give an update on the work that was done by Axine. As Chair said, that this report was presented at the last commission meeting. And Axine was there to make changes based on commissioners' response and feedback, especially on the financial results. And it was a bit challenging for commissioners to know what the bottom line of the financial impact on the legislation was. Since then, staff have met with Axine to make those changes and have summarized the financial impact in 3 takeaways. So the mandate is expected to increase premium by about 0.05% or about 37 cents per member per month in 2025. It is expected that a 2% annual increase in the percent of patients receiving the treatment because of the mandate. Finally, there will be a medical savings of about 2.5% total cost, or about 4 cents per member per month for each patient, for each new patient. Now, these results are shown in the attached revised report that was included in your packet. And also it includes the social and medical impacts of the legislation. MACC staff seek Commissioner's approval of the report, which is due to the Senate Finance Committee at the end of the year. I do have Axine online to answer any questions for the questions.
Thank you, Ken. Commissioner Galvin?
Sorry to have so many questions today, but I just would love to understand a little bit better, and it may just be my not getting it. But if there's a medical savings of 2.5%, which is 4 cents per member per month, how come we have to increase premiums by 37 cents? Wouldn't there be some absorbing of the savings?
Axine, are you online?
Yes, we are. So this is Joan Barrett from Axine Health Partners, and I'll happily answer the question. It was a very good question. So when analyzing the financials, there are 3 main components of it. One is, since this is cost sharing, you have to build in the price of removing the cost sharing for everyone who receives the service, even people that would have gotten it anyway. You also have a cost associated with new members or new patients coming on board, and that adds for cost. And then that is offset by the medical savings. So it is the cost sharing impact and the new patients that causes a net increase. Does that answer?
I'm sorry.
I think so. I'm thinking.
Thank you.
I'm sorry.
Go ahead,
Commissioner Douglas, just quick question. 37% see the increase. What is that annualized? You did that across, I'm sure, a number of members. What is the big number for the year?
In terms of total dollars, is
yes,
it's like 5 million, just under 5 million, spread across everyone. Are you asking that from the standpoint of the impact on the state or to the carriers?
to both actually.
Okay, well, the answer is the same for the total cost to the carriers would be the 5 million across all million members that are in there. For the state, and this was one of the issues that was brought up last time, there's a question about something called defrayals. And basically what that is according to the ACA, if the state mandates a service, then they have to reimburse CMS for the total cost of that state. They have to defray the cost. Now, there are arguments that maybe that doesn't really apply and arguments that it would apply. That is actually a legal issue, and I won't opine on the legal part of it, but I will make some comments. So when you're looking at this, there are several ways of thinking about it. One is that it's a new benefit, that the wellness visits are so important that even if there's a cost, it's worth it because of non-financial issues like quality of life and longevity types of things. There is another way of thinking about it in that if that this was really a preventive benefit all along, and all the mandate is doing is saying, yes, you can't enforce any cost sharing on it. The logic and the reasoning behind it for this particular benefit is that preventive benefits are governed by the United States Preventive Services Task Force. If you get an A or B recommendation for it's preventive, there's no cost sharing. It gets a little murky in determining how to draw the line on those things. If you go to the doctor and get your annual physical, he takes your blood pressure, all that. That's definitely a preventive service. So the question is this also a preventive service? the task force wasn't that clear on, on whether or not these should be covered. They say certain assessments should be done, substance abuse, anxiety, depression, etc. But they never say that it is really a preventive service. Now, we did dig into this issue a little bit more. There was a letter in 2015, I believe, that said that if all you're doing is impacting the cost sharing or demanding another type of provider, it's not subject to the defrayal rules, in which case it would be zero to the state. And between the two, my guess is that there will be no defrayals. But again, I'm not an attorney and won't opine on that legally.
Sounds like, I guess the point being here, you didn't feel it was within your expertise to address that legal question. And if it comes around again in Annapolis, the different parties on either side will be able to take their positions. Is that sort of a
Yeah.
fair?
Yeah, I mean, expertise, I mean, yeah, I mean, I'm not a lawyer and I won't issue legal opinions. That's kind of just a professionalism thing, and I would hope the other way around type of thing. But we did research it, and I would argue that it doesn't apply, but that would just be my argument.
And Joan, I might ask too, it might not be a legal decision as much as it is a interpretation decision from HHS and what they do.
Right.
They brought this up in the proposed rule for 2025. So this might be something that's, I'd say it's probably a lack of clarity more than anything, and it may be clarified in 2025.
Right. Very good point.
Commissioner Jeff?
To go back to an earlier question, just real quickly, let me take a run at this. So when you're looking at increased premiums and medical savings, is the denominator the same?
Well, the denominator is always the total cost, either expressed as total claims or premiums.
What I'm trying to get at is it possible that some of the costs and the savings don't go to the same people, or do they go
Right.
to the same people?
They do not necessarily go to the same people.
Mhm.
So, the cost.
That's why they don't.
Right, right. So, because what happens is.
You're
if you
paying, I'm
take-
saving.
Yeah,
Or no, I'm paying, you're saving.
yeah. So, everyone gets the benefit of the removal of the cost sharing, but only new patients are going to see the savings.
I think Commissioner Bazinski had a question.
Yeah, exactly. What is a new patient? Is that a patient new to behavioral health wellness visits? Or is that a new patient on the, like, newly insured patient? What is?
It would be new to the wellness visit.
So those are
People
patients.
that would not have gone to a doctor had it not been for this legislation, not gotten the wellness visit.
Okay, so you estimated a number of patients who would now get annual behavioral health wellness visits who currently do not. And because they get a wellness visit, they will not have future expenses because problems are being caught earlier, treated earlier at a lower cost center. So therefore, over the life projected time here, that patient would cost the system less because they caught things early. Is that an accurate
Yes.
assessment?
Right, yeah, so.
So
from
that
what I
savings,
can-
let me clarify one more. So that
Sure.
savings comes from treating things earlier rather than letting them be treated later at higher cost centers.
Yes, exactly. One of the things, and this is proprietary information from my former employer, but one thing we've seen a lot is patients that get the mental health care, you know, it is the early detection, but also they're going to take their drugs, and especially if they have a chronic disease, they're going to stick to the adherence to the drugs and save costs that way.
So,
So I have a question. If the patients, even though this could be a new law, if the patients don't actually participate in this and get the behavioral health wellness, just like patients have the ability to not get a physical every year, is it really doing the outcomes that we're predicting?
No, but let me add a little, again, this is kind of color rather than strict actuarial interpretation. What I expect will happen with this is that primary care physicians and word of mouth, people are going to say, why don't you go see a therapist? And when the person complains because it's going to cost too much, they'll say, no, there's no cost sharing. And that can be effective. Sometimes it takes time to build, but that's how it's going to happen. But you're absolutely right. If no one new comes, then we just give cost sharing to the people that would have gotten it anyway. And that's a risk you take on this, but it's a pretty small risk.
So is it just specifically them seeing therapists, or is it also them seeing like psychiatrists and psychiatric nurse practitioners?
Well, it's getting yourself in the system is the issue. One of the things, again, this is all kind of anecdotal, but what happens is a lot of people are ashamed to go get mental health care. But once they get in the system, regardless of how they get in the system, then they have access to care, they know about it, and they're much more likely to do what they're needing to do. This would apply, I think, to if the person went to their primary care doctor and the doctor said, okay, we need you to do A, B, and C. Or it could be they went directly to some other type of mental health, behavioral health specialist. Either way, it would get them into the system and get them talking and getting them where they need to be, hopefully.
One of the concerns, is that right? I mean, one of the problems that we have with evaluating these bills is we don't have next year's specific language. I'm not sure that it was envisioned that primary care doctors would be dispensing this particular benefit as opposed to therapists.
Right, which is why we included some language in there, albeit sort of subtle, about integrated behavioral health. There is a wide body of thought, both from just kind of the academic community as well as our carrier surveys that said we really shouldn't be sending people directly to behavioral health, get them in there with their primary care doctors, and there's not good access to providers. Let's make the best use of the resources. There are people that feel that way. There are people that think, well, why have a middleman? Why don't you just go to the doctor? I don't know that the intent of the legislation as it was written, or as you said, what it will be next year, is to say which doctor they go to. I think it's all about removing one barrier to getting them into care.
And I'm sorry, one more question on the nuts and bolts of this. Is there a E&M code for behavioral health wellness visit or CPT code?
I'm sure there is, because we pulled data, but don't ask me what it is. But yeah, and there are also diagnostic codes.
What's the code then? What's the code for a behavioral health wellness visit?
Oh, I knew. Let me see here.
I'm sure you know.
I'm sure Tony Distilli knows.
0401.
And then I just have one more question. With this behavioral health wellness visit, is that not going, I'm going to assume that's not going to require a prior auth from Medicaid, from Optum?
Not to my knowledge. It certainly didn't say it in the existing law, but I don't, usually.
Because in order to get services from Optum for any behavioral health, you have to complete a prior auth to get that. So I'm just wondering if that's also gonna, which is currently now a barrier to even being reimbursed for services. So
if that's the case, the law could be written to exclude prior authorizations. And maybe that would be a good add to the bill.
But yeah, just to be clear, we're sort of analyzing the where we are with this report is analyzing the factors that we're supposed to report on. And then there will be a turn of the bill with specific, if it comes back, it'll come back in a form, and I think it would be actual. We would actually have a chance to comment on it during the legislative session if the commissioner chose to do so. Just so you know that on the next iteration of these bills, we come up in a legislative session, we have our weekly in-session conference calls. So we will get to see the bills if they come back and comment on them where we it's appropriate to do so.
Yeah.
This is
Joan,
Commissioner Gilmore, I do have a question.
ahead.
For example, if a primary care practice has behavioral health integrated into their practice and this bill passes, would the primary care practice be able to, so they would actually, the primary care practice would be reimbursed for the cost of this behavioral health visit? Is that how it works? If behavioral health is already integrated into that primary care practice and not separate?
I would think so. Again, the bill's not very clear and there's an opportunity to shape it. You know, I in that instance, I would imagine that whoever the patient's primary doctor is would refer them to people within their own practice area. Now, whether there was another, you know, if that happened during a medical wellness visit and then they refer them to another specialist and they did another wellness visit, there might be two for one person, but I don't see that as a big deal in terms of cost. It might be from an access point of view and might be something that they need to build into the next law.
Thank you.
Joan, to answer the question about the diagnostic codes, generally these were coded as office visits, and we surveyed the carriers on this to see what their interpretation of this was. What was interesting is some of the carriers said they were primary care, some of them said they were specialists, but in general they were viewed as office visit codes.
Yeah, so that's the specialist primary care is an artifact of the mental health parity laws. Basically, that says that based on how you pay other services determines whether or not you can treat a behavioral health person as or behavioral health professional as a specialist or primary care. I don't know that you can necessarily change that in the law, but that would be another possibility for improving it, would be to make sure that it's treated as a primary care.
So do I have any additional questions or discussions about the report? Because we'll need to decide next about whether to send this report along or ask for changes before we send it along.
I'll just have one comment, and that is, I feel a whole lot better. I think I heard you saying that there are E&M codes for primary care docs, providers to, and hopefully for therapists to be able to charge for the additional service. I agree with this bill 1,000%. It's the right thing to do for people. But a lot what you hear out there in the medical community is that there are additional activities required in the fee-for-service practices without the reimbursement, and the savings doesn't go to the practices or even to the hospitals. The savings end up with the payers, and I've worked for a payer before, so I feel very ambivalent about all of it, but it has to be that the incentive is driven to the provider as well as savings to the payer for, in my mind, this and other things like it to be the most successful. Not to take away from this is absolutely the right thing to do.
Yeah, so one of the things that we came across when we were doing the literature review for this was exactly what you're saying, that there is an inequity, or at least a sense that there's an inequity. I didn't independently review that. But I felt like, there's a feeling out there that doctors, psychiatrists are not paid comparable to their counterparts in the medical field. And they're going out a network, which means if you have a network only plan, you're very limited. If I understand it correctly, that's part of another initiative within the MHCC. I don't know where that stands, but that's a different issue than what getting the person into the system. Related, obviously, but not the same thing in terms legislatively.
Can I get a motion to approve the submission of the updated mandated health insurance services evaluation, health insurance annual behavioral health wellness visits, required coverage and reimbursement, Senate Bill 108 to the General Assembly? Commissioner Boyle, can I get a second? Commissioner Stratton Duncan? All in favor?
Aye.
Are there any opposed? Board passes. Thank you.
You're
Move on
welcome.
to number 6. I'm not the hot seat yet. And
I
item
don't
6,
mind the hot seat.
diagnostic supplemental exams and biopsies for breast cancer, cost sharing, SB 184, HB 0376. MACC staff received a formal letter of request from the Senate Finance Committee to evaluate Senate Bill 0184, House Bill 0376, introduced during the 2023 session of Maryland General Assembly and passed. The legislation will be enacted into law effective January 1, 2024. MACC staff contracted with Axine Health Partners, an actuarial consulting firm, to evaluate this past legislation, which would require health insurance carriers not to impose any cost-sharing requirements on coverage for diagnostic breast examinations or supplemental breast examination. Greg Fan, a consulting actuary with Axine Health Partners, will present the findings of this study before asking the commission to approve the report. Greg?
So, Mr. Chairman, just
Yes.
Greg, before you begin, so since the last meeting, I think I was the one that raised the question of defrayals, and the MIA reminded MHCC that under the statute that established the essential health benefits for the Affordable Care Act, in that language, section 3116 of the insurance article, it states that additional mandates not recognized as part of that statute would not apply to the individual and small group market unless they were explicitly included in a mandate. And that has been governing ever since. So unless the legislature said this or any one of the 4 mandates we discussed today applies in the small group market and the individual market, which are subject to essential health benefits, that they would not apply. So the defrayals are off the table in the judgment of the MIA, unless the statute or the bill says, no, this applies to small group and individual market as well. There's been only one mandate that has passed where that has been employed, and that pertained to reproductive health benefits that we specifically said this applies to small group and individual. So we don't need probably to talk anymore about defrayals today.
Okay, and thank you. And what I mentioned earlier, I think would echo that if the federal government makes the change, the clarification that we expect them to make. I'm actually going to let Joan Barrett, my colleague, who was a speaker on the last discussion item, do the presentation here, and I'll stay on the line. Joan?
Yeah, thank you, Greg. So can you go to the next slide, please? I'm going to keep this brief because it's pretty duplicative of the conversation we had before. So one difference between the prior bill and this bill is this bill passed. And it is, again, eliminate cost sharing. So it's not like we're adding a new benefit. Biopsies are covered now. It's just that they're covered at a cost. So next slide. So I'm just going to focus on this slide. So breast cancer is something that if you're a woman, you live in dread of. 1 in 8 every women have some form of breast cancer in their life. And of course, it's easier to treat, and the chances of survival are better if you detect it earlier when it's a small nodule or a lump rather than when it's spread. There is a procedure for screening for breast cancer. You start with a self-examination. Women are told to do it monthly and given instructions on how to do it. There's a clinical exam, which is very similar, but it's done by a doctor. And then there are screening mammograms where you actually go into an office, they take a picture and try to see if there's any abnormalities in the picture. If there is something that looks suspicious, then what happens is they do perhaps a second mammogram or a different form of imaging. And if it's still suspicious, they do a biopsy, which is just basically taking some of the tissue out of the breast that looks suspicious, send it to the lab and test it for malignancies type of thing. And the biopsies are really the only way to confirm a cancer diagnosis when it's present. So, so this is to basically cover that image-guided diagnosis. The reason that is important is because if you're catching something early and the abnormality is small, the image guidance gets a better chance that you're actually going to get part of that malignant or potentially malignant material and not other breasts. So it reduces the false negatives on this type of thing. I will say that I know we're not going to talk about defrayals, but I am going to mention what's covered under current Maryland law. So the way current Maryland law works is everybody agrees the mammogram where you go in and you take that initial screening is preventive and there's no cost sharing. The question is, what about some of the follow-ups, and the biopsies would be a follow-up. According to the Maryland law, they go by some published guidelines, and the published guidelines say biopsies are part of the initial screening. Not everybody may agree with that, but that's what my basic reading of it said. In terms of cost, it's very close to the cost for the behavioral health. It's going to be very small, but it is still the same 3 components. The cost share that happens to everyone, the additional screenings that this can generate, and then the medical savings on the additional screenings. So I don't think since we talked about it in depth before, I think I'm going to pause here and see if there are any questions.
No questions? You want to?
She was never.
Sounds like we can.
Hi, this is Commissioner Gilmore. I do have a question, but I think it's in one of the later slides, slide 6. So I don't know if you want me to ask that question now or wait until then.
We can go to slide 6. I basically hit all the highlights, so I wasn't going through the remaining slides, but we can go through to 6 if you have one.
You do slide 6 and then slide 7, if you don't mind, after slide 6.
Sure.
So I had a few questions regarding this slide. My first question was, this 5-year survival rate. Is this for the state of Maryland or is this a national rate that you provided? And is it both male and female breast cancers or just female?
Well, so for 5 years, so it's actually a later slide. It was, I think that particular slide was just female and it was national numbers. It wasn't just Maryland. Those studies are pretty intense to do, but yeah, it's a national number. And there's really, usually I try to look for Maryland specific numbers when we're looking at a mandate for obvious reasons. But I don't think, other than perhaps some racial differences and those types of, kind of a population mix, I don't think there's any reason to assume they're any different for Maryland than the others. Did you have a concern about Maryland or?
No, not necessarily a concern about Maryland, but I guess I have more so, I guess, a question. This may not be the place to answer that question, but in addition to, I'm just looking at the 5-year survival rate. I know there's a significant difference in the survival rate between Black women versus white women, both in the state of Maryland and both nationally as well. And I'm just wondering, in addition to eliminating the cost sharing, what other plans or initiatives will take place to kind of increase the survival rate of Black women when compared to white women and women of other races around breast cancer. And I noticed even though white women tend to have a higher incidence of breast cancer than Black women have a higher mortality rate. So they're dying more.
Yeah. So that was not part of this, but I'll speak to it anyway. And
Actually, that's okay. I'd like to stay within the scope of your report here.
Sure, that's fine.
We could certainly, as a commission, address other issues and other initiatives. So Ben,
That's fine.
Take that under advisement. I will. Could you flip briefly to slide 7 with the financial analysis?
Mm-hmm.
Almost there. One more.
Yeah.
And just for the commissioners, this is how the numbers add together. They did it on this one. So that you see the additional costs minus the medical savings times administrative factors, how they got to the 39 cents. I just wanted to point that out for folks. This is not a large dollar amount, but I did want to ask on cost sharing if because the individual and small group market have plans set at specific actuarial values, bronze, silver, and gold. So it's fit 60% actuarial value in the bronze level. That means on average across the whole book of business, 60% of the costs should be spent on benefits and by the carrier and 40% should be cost sharing. If you reduce the cost sharing for one of these benefits, for some of those plans, you may just be increasing it on a different benefit to stay at that 60% level. Again, this is a small amount, so probably not on this, but is that do you take that into account in your analysis, or more like it might not be a 33-cent increase because some of the consumers may just be moving cost sharing to some other benefit? I don't know if that's part of your analysis or just outside of, in addition to it.
I'll take the question, Joan, if you want me to.
Sure.
Yeah, it's not part of our analysis. And there is a plus or minus 2% de minimis ratio on the actuarial value. And given the change in this, it's immaterial. So it's possible it could have an impact, but it's probably unlikely that it would.
And I was asking that really as a general matter. That's sort of true for all of these where they're cost sharing. I won't ask it every time. Is that you're just, this is the total cost. It goes somewhere, either into premium or it gets shifted somewhere or something like that. Okay.
Yeah, so actually, one thing to keep in mind with these deductibles are pretty large on the ACA plans. And not that many people reach the deductibles. It's less than half the people meet the deductible, in which case those people are getting a net increase. But you're right in terms of people that that hit the deductible, and then if they hit the out-of-pockets, it's irrelevant. So it's kind of funky how that plays out. But you're right, and that's something we could add to future ones, is to add a section on not just the overall cost to the payers, but how it would impact some individuals, but that wasn't within scope for this one.
Thank you. Are there any more questions? If not, can I get a motion to approve the submission of the diagnostic and supplemental exams and biopsies for breast cancer cost sharing SB 184 HB 376 report to the General Assembly?
So moved.
Commissioner Gelroy, can I get a second?
Second.
Commissioner Douglas, thank you. Any additional discussion? All right, all in favor?
Aye.
Are there any opposed? Report passes. Thank you. And I did note that we should have a further plan in which we could discuss the issue of breast cancer initiatives more general. Agenda item 7, treatment of alopecia areata coverage, if I'm pronouncing that correctly, coverage requirements, SB 75. MHCC staff received a formal letter of request from the Senate Finance Committee to evaluate the legislation Senate Bill 75 introduced during the 23 session of the Maryland General Assembly, but failed to pass. MHCC staff contracted with Milliman, an actuarial consulting firm, to evaluate SB 75. AC Hammer, a consulting actuary with Milliman, will present the findings of this study before asking the commission to approve the report. Casey.
Can you all hear me?
Yes.
Perfect. All right. Hi, I'm Casey Hammer with Milliman. I am a consulting actuary. So I do want to preface this when I'm talking about the social evaluation and the medical effectiveness section that I am not I'm not an MPH nor am I a clinician. So I'll preface with that, but I am summarizing the sections that were produced by people with those skill sets. So
just to be clear, though, the report that we're sending in did have people with the skill sets. You just got to be the lone presenter on point, which is why you're trying to explain that.
Exactly. Correct.
Okay. Thank you.
So first of all, if you go on to the next slide, we'll go through a bill summary, some of the medical background, the social impact, and then finally get to the financial estimates. So next slide, please. So Senate Bill 75 would require the following, and this is summarized from the bill text. First, it would require the Medicaid program to cover one hair prosthesis for each recipient whose hair loss results from alopecia areata. The second thing, it would be for the Maryland Medicaid program to cover the prescription drugs and medical devices approved by the FDA for the treatment of alopecia areata. And the third is that commercial insurers, they're subject to state benefit mandates. That would be that would not include your self-funded groups or ERISA plans to cover the cost of one hair prosthesis up to $350 if it's prescribed by the physician treating an enrollee or insured for the alopecia areata. So one thing to note, and what you'll see is later in the financial results, is that there is a limit on the commercial insurers as far as the cost of a hair prosthesis, and there is not a limit on the Medicaid recipients. So there will be some differences there. And additionally, only the Medicaid recipient, we only looked at the Medicaid population when looking at the FDA approved drugs. Can you go on to the next slide, please?
Excuse me, this is per year, not just one.
Is one
Correct.
per year, per year.
Per year, yeah.
One per year, okay.
Any
So
idea
first,
how long one lasts?
hair prosthesis, they vary in quality. So it really depends on what you purchase and how well you take care of the wig or hair prosthesis. So I would say it would not be uncommon for someone to have to get one at least once a year or more than one per year, depending on the quality of the wig that they provide. So there's just so much variability. It's hard to say like how long one might last. So alopecia areata is an autoimmune condition that causes hair loss. and it typically affects the head and the face. So there's a few different types of alopecia areata. There's the patchy alopecia, which causes coin-sized patches of hair loss. There's near or complete hair loss, the alopecia totalis. And then there's alopecia universalis, which is complete or near complete hair loss on the scalp, face, and the rest of the body. Next slide, please. So currently there are, the treatments are intralesional corticosteroids, and those are injections that are like applied directly to the area that's impacted. So it's the treatment of choice for patients with less extensive patchy hair loss. And lately, like approved in 2022 and 2023, there were two Janus kinase inhibitors that were indicated for severe alopecia areata. And these drugs are systematic. So they are an oral treatment to to treat the autoimmune condition, not just to try and promote hair loss within that one patch where they're receiving the corticosteroids. Both of these drugs were found to be significantly more effective than placebos in treating alopecia areata. Cool. Next slide, please. So within the Maryland population, we see the prevalence of alopecia areata is 0.2% pretty much across the board, which is in line with published statistics. That's not too far out of line with something that you might see from like the Alopecia Foundation. The state health plan was a little bit larger than that, and you'll see some volatility from smaller population sizes and things of that nature. The studies have found that Black, Hispanic, and other multiracial patients do have a higher prevalence rates than white patients, and it's also higher in women and adults as compared to men and children. So any, I guess like this mandate would impact those populations more than it would impact the white patients and children. Next slide, please. So for hair prosthesis, we conducted a survey of the insurance carriers, and we found that individual state health plan and Medicaid enrollees do not currently have coverage. 5% of small group enrollees have coverage, and nearly 30% of fully insured large group enrollees have coverage. One thing that I do want to note, though, is that under the HHS 2023 final rule, the federal regulators refined their essential health benefits non-discrimination policy. And this policy requires coverage of benefits to be based on like clinical need instead of condition. And right now, the state of Maryland covers cranial prostheses for breast cancer patients, or sorry, cancer patients. And so these rules, as they're applied, like you can't just say, oh, it's now only covered for cancer patients because cancer patients are, they went bald as a result of their condition. So like that would be condition specific discrimination. And so as these rules play out, it's unclear, like we did, survey the carriers, and this is what they said, who has coverage, but it's unclear if once these, like the regulations are implemented, or if they will become covered, because technically they should be covered under this final rule. Does that make sense? I want to pause here because that's an important caveat to this study.
I think it looked like it made sense to folks. I guess my question would be to carry that one further. Are there other baldness conditions that also would require coverage under non-discrimination rules then? Because this bill, I was gonna ask this about this bill, like where it says, I don't know how much baldness is alopecia versus something else. So are there other conditions that would similarly fall within the non-discrimination, or if coverage were added here, would there be something else that would be discriminatory not to cover? Does that make sense?
Yeah, that was beyond the scope of our analysis. I mean, we were focusing specifically on alopecia related hair loss, but it could expand to that. And if there's other benefits within Maryland that may be condition specific, you know, this final rule may impact those as well. But again, that was beyond the scope of this analysis.
Okay.
So in our financial analysis to follow, we used the carrier coverage survey to frame our analysis. But if the regulations are followed, and you know, it does take sometimes for insurance carriers to catch up, then you know, they may already have a coverage, in which case the impact on those populations would be zero for the enrollees in the ACA market. Moving on, the JAK inhibitors, they are, the carrier coverage survey indicated that 76% of Medicaid enrollees currently have coverage for those drugs. Next slide, please. So there's not a lot of, like we can't rely on claims data for wig utilization, and there's not like a database of who owns a wig. So for this study, we are relying on statistics based on surveys, like who's interested and who has one. So and this is noted as a limitation within the study because people who are going to respond to the National Alopecia Areata Foundation survey may be more like that population may be biased as far as like how they're responding. You know, like the ones who are using a hair prosthesis may respond more than those who aren't. And there's not a real way that we could justify adjusting it. So I would say that maybe it's the 93% who are considering getting a hair piece that may be a little bit overstated, but I don't know by how much, if that makes sense. And then
Is the thought that people with more severe alopecia are more likely to respond? Is that
right? If you're responding to a survey about hair prostheses, you may be wanting to change the coverage for hair prostheses. I don't know how the survey was conducted. If it's like, oh, we use this information to guide policy or to for these types of reports, then those people might feel a little more inclined to respond. So that's where we think it might be a little higher. But again, we don't know like how we would adjust for that. It's just something to keep in mind.
Well, also patients associated with a patient organization tend to be more proactive anyway.
Mm-hmm.
So I would think what you're saying makes sense.
So we did not make adjustments for that, but it's just something to keep in mind. Is there? So of those 93%, 85.7% actually got one. So the most common limitation to receiving a cranial prosthesis is cost. And so we relied on these values in order to frame our utilization of this benefit if it were to pass. One other thing to note here is that the survey sample was predominantly female and reported having greater than 50% hair loss. So that's not necessarily, like there's, as we mentioned earlier, there's some that are patchy and some that are, less than 50% hair loss as well. So it's more severe case. You go to the next slide, please. So our financial evaluation, we projected under two scenarios. The baseline is that the proposed legislation does not go into effect, and post-mandate is that the legislation does go into effect. And the difference between these two pieces is what we calculate as the impact of SB 75. So some of the key assumptions, especially in the annual values, we have access to one cranial prosthesis annually. Again, as I mentioned earlier, the commercial carriers cover the cost of one cranial prosthesis up to $350, and Medicaid is required to cover the entire cost of the cranial prostheses. We assume that the drugs traditionally used to treat alopecia are covered, so we did not look into those corticosteroids. We only looked into the new JAK inhibitors, and the financial evaluation only includes the impact of those two systemic treatments. Next slide, please. So with that, we estimated the number of enrollees with alopecia areata, and that was based on the prevalence values that you saw earlier. And then we estimated the number of people who are using the cranial prostheses at baseline, and that's based on, that interest slide that we saw earlier as far as like from that survey. And then, so we assumed that anybody who had got the cranial, like, so that 86% of the 93%, that's who we're seeing here at this baseline of those who are interested and also received one. The users of cranial prostheses post-mandate is, that total 93%. So the change in the users of cranial prostheses is that differential. So one thing to note is that in the Medicaid population, we assumed that there was not any users at baseline due to cost. So this is, again, it's an assumption. We're not aware of, there is not a database to indicate that. And then, that 93% of people would be interested in possibly receiving that. And also that, the individual and small group, this, depending on how the final rule is implemented, then we, there may be no impact here. So on the next slide, please. Based on a survey it was that same survey that was done, we took the average cost of a cranial prosthesis and we trended it forward. And based on, like, there's a lot of other numbers, and you can go into the methodology section as far as how we balanced the coverage versus how much was covered versus who was paying what when they weren't covered and all of that to come up with this cost for users with coverage and then the cost for users without coverage. So what the study seemed to indicate and what we assume, like between what the study indicated and some assumptions, we assume that people with coverage are paying more for their cranial prostheses. Like I said, there's a wide range of quality and cost for these types of for cranial prostheses. So users with coverage, we estimated an average cost of $2,170. And for the users without coverage at baseline, so those who are just paying out of pocket, we assumed $1,480. So post-mandate, the users who had coverage, we're not assuming any change in the quality of the wig or the cost of the wig that they decide to purchase. For those who were purchasing a wig prior to at baseline prior to having coverage, we assumed that they would take that $350 and apply it towards a higher cost wig. So it is possible that some of these new users or these users without coverage at baseline actually use it to pay down the cost of their existing wig. But when we're talking about like what the change in the user cost sharing would be, or like the non-covered benefit, this is what we assumed. So it may be overstating that. For new users without coverage at baseline, we assumed that that cost was the barrier to receiving a cranial prosthesis, so that they would only purchase a solution of up to $350. So they're not spending anything additional out of pocket. They're purchasing a product that costs $350. Without because there is not a cost limit in place for the Medicaid enrollees, as far as like there isn't a benefit limit, excuse me. We assumed that those users post-mandate react similarly to those with coverage at baseline and purchase a $2,170 cranial prosthesis. Next slide, please.
Next slide.
So, now for the JAK inhibitors, because they're so they're newly approved, so we don't really have any utilization data to go off of. Like, it has not come through for us to actually build a utilization statistic to be able to apply to see how are people using this. So we relied on our clinician to come up with scenarios, and based on the severity distribution of the enrollees with the different types of alopecia and how many she thinks might be interested in this type of more comprehensive treatment. And so at baseline, because some people have coverage, the 76%, we assume that there's somewhere between 70 and 340 users, and that expanding this coverage would lead to 30 to 100 new users, so that there's somewhere between 100 and 440 users post-mandate. The cost per script of one of these JAK inhibitors is between around $3,000 and $4,500. Now, this is based on the list price without any discounts. It's hard to know exactly what Medicaid is paying, but based on the information that we could find, this is as close as we could get as far as an assumption to the cost per script. So we did include an $11 dispensing fee, and we assumed a $1.50 co-payment for per Medicaid user. And we also offset for those who we think may have been receiving the intralesional corticosteroid treatment. Some of those people may switch to the JAK inhibitors, and so we did offset that cost by $55. So as I was mentioning before, like it's the under the low scenario, our clinician assumed that 5% of the untreated patients switch and 20% of the treated patients switch. And under the high scenario, it's 50% and 70% of treated. Next slide, please. So moving on, when you take all of that together, the per member per month increase due to SB 75 is between 5 to 7 cents for the total fully insured commercial market, 10 cents for the state health plan, and that's because, as you remember earlier, there's slightly higher prevalence in that population. And for Medicaid, it's between 33 cents and 54 cents. And there's a couple of reasons for the Medicaid one to be as high as it is. One is that we're assuming the total cost of the cranial prosthesis is covered by the Medicaid plan, and that the second one is that we're also including these JAK inhibitors. So the depending on which scenario for the JAK inhibitors, we see the the 6.2 versus the $10.3 million increase. So next slide, please. So now we kind of go into some of these things to consider when you're looking at these values. So the again, we're looking for like the 92% may be high or low depending on the extent to which male usage is different, and the different severity levels of those who were interviewed or surveyed versus those who would be are within this population. We did assume that people would use a more expensive cranial prosthesis, and it's possible that some of those enrollees who are currently using it and paying for it completely out of pocket would use that $350 to offset that. So so the savings to the user may actually be higher than what's stated in our report, but it's hard to say how someone would actually use that benefit. So it's kind of like thinking of it as more of like a top end estimate. So like keep that in mind. We relied on the treated and untreated statistics to create the low and high end range statistics. But these statistics were from time periods prior to the availability of the 2 FDA approved drugs. So the patterns may change based on the introduction of these to the market. As noted earlier, we have that the HHS final ruling, which may indicate that the small group and individual ACA markets are not impacted by this. And then we have the next slide is just really some of our more standard caveats, that we're making assumptions here, and actual results will differ depending on how well reality conforms to what we assumed, and so on and so forth. So with that, I'd be happy to take any questions.
Are there any questions?
My question, thank you for your presentation. My question is just more of like a clarification. You mentioned the assumption around purchasing the prosthesis with individuals who don't have coverage, but they are using the $350 that will be provided as a supplement. Why did you make that assumption rather than the latter, where patients will replace their out-of-pocket costs with the new benefit? What led you to that assumption rather than the latter?
I don't know that there is anything that led us to that assumption. It was really more like, because we don't know how they're going to use it, it's either pick a top end estimate or a low end, so that way it kind of frames what the expected cost might be. So you could assume, 100% apply it to pay down some of the average costs. And that would also be give you an idea of what that savings would be for those enrollees. But it was really more to give like I said, just to frame it versus like, oh, we think it's going to be this way versus this other way.
So just to clarify, if I could, Casey, so that could be, I think what Dr. Blake is saying is that number could be between roughly $1,125 and $1,830. Could be within that range for users without coverage today. If you wanted to give a range. Some people who have access to that benefit would have offset what they already spent out of pocket, and others would have used it additively to what they already paid out of pocket themselves. But you're
Right.
saying we're basically tilting towards people will continue to spend what they have spent and use it as an additive benefit should this method pass.
Correct.
Just curious to know, why isn't there a dollar limit for Medicaid?
That's, okay, I was gonna say, that's not a question I think that I can field. We analyzed it as it was written and how we interpreted it, but we did not see a dollar limit applied to Medicaid.
In the bill that you're analyzing.
Mm-hmm.
Yeah, I don't, this has been discussed it was suggested it was going to be introduced in 2022. I don't think it materialized in 2023. I can't really say why they drafted the bill they did, but clearly the sponsor had maybe a particular thought that the Medicaid benefit would be more open-ended. I'm not sure, but we can find that out. I would suspect.
But for this report, though, I mean, if the legislature picks it up and they pick up and they have a bill where they say what they're going to put a dollar limit in it, they'd be able to use this report to adjust the numbers, I would think, wouldn't they?
They could, yes.
Like, so we're still giving them the information that they would need to evaluate.
Yeah, I think that, to the extent the legislature, is very interested, it's what's the PMPM member impact. And I'm not quite sure, Medicaid will remind legislators that it has a financial impact on the program itself. Medicaid is always, very sensitive to additional costs to the program. It's a taxpayer funded insurance program as opposed to private insurance coverage. So your observation is kind of interesting, because usually it might be less, but here it's actually more. So I'm not sure why that is.
Any other questions? With that, call for a motion. Do I have a motion to approve the submission of the treatment of alopecia areata coverage requirements SB 75 report to the General Assembly?
So moved.
Commissioner Douglas, thank you. Is there a second? Thank you, Commissioner Boyle. All in favor?
Aye.
Are there any opposed? It passes. Last one.
Mr. Chairman, just a comment that's tangential to this. So we were asked to provide this summary and related to alopecia, and it's interesting to me, as Commissioner Spinner spoke to, there's no Medicaid limit on prosthesis or treatment. And I would like to know, how do we get to look at this from the perspective of obesity and the use of now approved injectable obesity medication for Medicaid members? There's 5 states that do cover this, Maryland not being one of them. And when we think about all the sequelae to obesity and chronic diseases that are tied to that, I would love for there to be some work on looking at the risk-benefit alternative to having medication to treat that disease for Medicaid members.
Thank you.
So I think I would ask Milliman a question here at this point. Casey does work on the California Health Benefits Review Program, which is a program in California that provides estimates to the California legislature on insurance mandates. Has California studied the kind of the framework that that Commissioner Gelrud outlined to you in anything you've done recently? I don't know if you picked up her question or not.
On obesity drugs?
On obesity drugs, correct.
There is, I'm not sure, yes. I'm not sure if that one is public yet. If not, it will be soon. I would have to look into that and I can forward that to my contacts at the MHCC if you're interested.
Yeah, so my suggestion would be, so the California Benefit Review Program is kind of the gold standard among states that do this sort of thing. Principally because it's been in place for a long period of time. And we look to what they do. So we might be better advised to see what information we can get that California gets. Obviously, this proposed legislation probably would look a little different, but that might be a guidepost, and we can bring that back to the commissioners and talk about whether we should do more kind of as our own commission mandated study as opposed to a legislative mandated study. I also suspect
Or
that,
we could also share with Department of Health.
Yeah, yeah.
For Medicaid.
Right.
In the first instance.
they might be asked to pick that out.
Thank you.
So agenda item number 8. Labor and Delivery Services, Coverage Cost Sharing, SB 784. MHCC staff received a formal letter of request from the Senate Finance Committee to evaluate the legislation Senate Bill 784 introduced during the 2023 session of the Maryland General Assembly, but failed to pass. MHCC staff contracted with Milliman, an actuarial consulting firm, to evaluate SB 784, which would have required health insurance carriers, including HMOs, to provide coverage for labor and delivery services without certain cost sharing requirements and generally relating to cost sharing requirements for labor and delivery services. Casey Hammer, a consulting actuary with Milliman, will present the findings of this study before asking the commission to approve the report. Casey, please proceed.
Right. That's a great summary of this one. I feel like this one's a little simpler as far as what the request was.
Don't feel that you need to repeat anything that I just said.
Right. Okay, let's start flipping through some slides. The agenda is very similar to the last one. So we already know what keep going. We know the requests. We'll go to the labor and delivery background here. As far as labor and delivery goes, we defined it. When we're thinking about labor and delivery services, we're only looking at the time at which someone checks into the hospital to do the labor and delivery portion of their entire maternity service, and to when they check out. So it's not looking at any prenatal or postnatal care associated with that. So I'll level set with that first. The American College of Obstetricians and Gynecologists and the American Academy of Pediatrics have advised that hospitals and birth centers are the safest place to give birth, and there are no clinical practice guidelines that suggest that people should be giving birth unattended. Next slide, please. So as far as insurance coverage for labor and delivery goes, the Affordable Care Act requires non-grandfathered individual and small group plans to cover labor and delivery services and as an EHB. And the state of Maryland has required that large group and grandfathered individual plans cover labor and delivery services. So some small group grandfathered plans may not cover labor and delivery. We did not, it's a small percentage of the population if they are out there, and we did not make any adjustments for that in our analysis. Next slide, please. So as many of you are probably well aware, there are a lot of different health plans out on the market. And one of the things that you need to consider when doing any kind of cost sharing elimination is you're not just eliminating the cost of that labor and delivery. So it's not as simple as saying oh, they had a $500 copay, so they're going to save $500, because the cost of those benefits or your benefits accumulate over the course of a year, and oftentimes towards like a deductible or an out-of-pocket maximum. And oftentimes your facility, so your inpatient or outpatient hospital charges, will accumulate to a deductible and an out-of-pocket, and everything accumulates to your out-of-pocket maximum. So those pieces need to be considered whenever you're doing some type of a cost share elimination study, because, for example, there are going to be people who, you eliminated their cost sharing for labor and delivery, but after that they, broke a leg or had a heart attack or something of that nature that landed them in the hospital, and now they're going to meet that deductible and out-of-pocket maximum, regardless of that labor and delivery cost sharing being removed. It's just more of a shift of the timing. So for some people, you will see savings, and then for other people, there's no actual savings that would be applied because these other services are, requiring payment that would maybe be free to the patient if they had met their out-of-pocket maximum or deductible via labor and delivery. Does that piece make sense to everybody?
Yes.
Okay.
Well, speak for everybody, but it made sense to me.
Okay. So, so part of doing this type of analysis requires, in effect, like repricing health insurance benefits. So what we did when we surveyed, we surveyed the Maryland Insurance Administration and fully insured large group insurance carriers about what their most popular plan designs are. And the reason for that is because it's a very manual process of going through and trying to figure out how would the cost sharing be applied if there was labor and delivery versus if there was not labor and delivery for each member. We got a wide range of benefits. There are enrollees and plans where the richest benefits are $0 out of pocket for labor and delivery, or there's a co-payment per admission, so they're not subject to these deductibles and co-insurances. And then those with leaner benefits are subject to those higher deductibles and up to 40% paid by the patient for the labor and delivery services. And that would be more like your bronze middle tier plans and plans with your higher deductibles.
Excuse me, Casey.
Mm-hmm.
Commissioner Brzezinski here. May I interrupt briefly?
Yes.
How does I thought a lot of labor and delivery were paid global as part of the prenatal care as well. So, but I know like for Medicaid, it's often paid labor and delivery separate from the visits, the prenatal visits. So does this look somehow for those global fees for prenatal care and labor and delivery change? Like, are you able to account for that? Or if it's a global plan that, pays for the entire pregnancy and delivery, just leave that in there as a cost?
So that's, and that's outlined as one of the limitations of the study, because it is unclear based on the data that we had access to, how the billing actually happens for that. So in those situations, it's unclear if they're submitting a claim for every prenatal visit, for example. Are they submitting a claim for those 9 months? And even though it's being paid as a bundle to the provider, it's, they're just accumulating those visits, right? Or if they are being billed all at once at the very end. Because the way that we identified labor and delivery within the data set is, so for each member who had a labor and delivery, so with labor and delivery being defined as, delivering a baby, so not just someone who had a maternity care. We looked at the admission date and the discharge date, included any claims that were submitted during that period, and included those as a part of the labor and delivery cost. So if there is some of that prenatal visits that are being billed during that period, we were not able to make an adjustment for that.
And it's your understanding in the reading of this legislation that they meant to exclude prenatal care if it was billed separately from the global.
Right.
Interesting.
And that was confirmed by the commission. We had a discussion about that with my contacts at the MHCC.
Thank you.
So that is a limitation, is there could be some services that are included in this component that should not be, and others that I don't know if they build up front for some reason, like that those services would not be captured, and so we're unable to figure that out based on, like I said, the information available. Like I think we would have to have full access to the APCD and some it would be a deeper, more costly investigation in order to get to the bottom of that. So we surveyed the oh, we got through this slide already. Can you go to the next slide, please? So our financial evaluation echoes the alopecia bill, where we look at baseline the enrollees are paying their deductible, co-insurance, co-payment, or any other cost sharing on their labor and delivery services. And post-mandate, we looked at each individual who had a labor and delivery service. We looked at their pre-labor and delivery charges for like what was considered an office visit, everything else, their labor and delivery, then post-delivery office visits, everything else, and we carved out preventive, because preventive services are going to have zero cost sharing. And so we asked high level from the carriers, because I mean, if any of you have looked at your statement of benefits, there's a lot of things to consider, and each piece has its own benefit and cost sharing assigned to it. But at a high level, we asked for some parameters from the carriers, so that way we can model that shift of or potential shift of the deductible and out-of-pocket maximum pieces coming service being applied to services that happen after the labor and delivery in the post-mandate world, when labor and delivery goes to zero. So so we, like I said, we looked at that at the individual level and rolled up those results. So it's essentially like a repricing of the claims, a high level repricing of the claims for each benefit plan design received by the carriers. Here, the next slide, please. So some key assumptions within our analysis is we carved out the health savings account qualified high deductible health plans. And that's because but labor and delivery is not one of the services that's allowed to be without cost sharing, and also have an HSA attached to that plan. So, either like if it were to be applied to these HSA qualified HDHP plans, they would no longer be allowed to have an HSA. So we carved those out. We estimated the birth rate for non-Medicaid populations to be about 8.8 per thousand. And we tried to select a set of plan designs that represented the commercial for fully insured lines of business. And those plans represent the most popular plans by the metal tier deductible level. Next slide, please. So this gives an idea of the number of the total estimated count of deliveries and how many would actually be subject to the mandate, and that's based on carving out those non-HSA deliveries. So only 40% of the deliveries in small group would be subject to this, and then 92% in the individual plans would be subject to this mandate. Next slide, please. So the average cost of labor and delivery is $21,750. And the at baseline, the cost sharing is $1,120, and post mandate that would be $0. Next slide, please. So the as you can see here, the cost sharing that's applied is going to vary a lot based on the benefit design that someone has. So in small group platinum, it would be a $230 average based on that that most popular plan design. And in the individual bronze category, we're seeing a savings of estimated cost sharing of about $3,900. So there's a lot of variability in the impacts. And within the fully insured large group plans, that cost sharing is about $230. And then the state health plans, like depending on the plan design, you know, the PPO and the IHM do not have cost sharing. And so that cost sharing is $0, and then it's $1,140 for the EPO. One thing to note on the, and we'll get to this in the limitations, but since we're here, the fully insured large group, we surveyed the carriers, and we didn't get a great response on that. One of the carriers, and the actual stats on it are on a later slide, but one of the carriers had a disproportionate percentage of the response, but they had no cost sharing on their labor and delivery. And so that may or may not skew that fully insured large group lower. I don't have the data to be able to say what other large groups are, or what other insurance carriers are applying to their large groups. Next slide, please. So taking all of that into consideration and rolling it all up, we get to a per member per month increase of about $2 on the individual line of business, and 20 cents on the fully insured large group. And on the state health plan, it's about 80 cents. So for the total commercial, we're looking at about a 90 cents PM with a total annual increase of about $9 million. Next slide, please. So as I was mentioning earlier, the carrier that had on the large group, the carrier with the full responses across the board for all the deductible levels that we were asking about, they had approximately 20% of the fully insured large group market, but they comprised over 70% of our survey enrollees. So it really was disproportionate on the amount that their responses had on our results. So take the the large group is not as I would say.
So what you're saying there is though more of your survey respondents said, hey, I have no cost sharing on this already, than might be the case because got a lot of responses from that one carrier where they were already not having to pay cost sharing.
Correct. So our results for the impact on the fully insured large group market may be lower than actual because that one carrier who they gave responses, because we broke it down by deductible category. I think there were 4 or 5 deductible categories that we asked for, and a couple of the other carriers may have provided one plan design for one line or one deductible level, and the one carrier that had nothing across the board as far as their cost sharing, they provided something for all of it. And so they do represent 20% of the market, but they were 70% of the market for our survey enrollees. So so that's a that's a pretty we're relying on that one pretty heavily. So and we extended the deadline for that, and we just weren't receiving additional data, so we just moved forward with it. So that's a pretty large caveat on the large group market, on the impact of that. the second consideration is, to your point earlier, that, some of these services could have been billed prior, or some of them could have been billed during the labor and delivery. And so, we are not able to discern between that. And so that's just another consideration to this analysis. Our methodology assumes that each user only had one delivery in a year. It's possible that someone could have more than that, but we assumed one. We're using the most popular plan designs. Sorry, next slide, please. We are using the most popular plan designs by tier deductible level as a proxy for the entire market. So to the extent that those plan designs differ, that might not reflect the total commercial market. Again, plan designs are complicated. We are making some generalizations to what would be subject to deductible and co-insurance versus a co-payment for these other services, and what those services might be, because it would be a much more intensive and much more costly analysis to reprice healthcare coverage for each plan design in the state of Maryland. So this is, think of it more as getting into the ballpark, not being a complete accurate picture of like, this is exactly what it would cost. It's more of an estimate of what those other benefits would be in order to get the to account for some of that accumulation to the deductible and out-of-pocket maximum from these other services.
Can I ask you a question? I'm concerned on this mandate about the impact specifically on the bronze middle tier. I'd like to know if you've evaluated it, but if the way you develop your rates is you start with a rate of your entire individual market or your entire small group market, and then you add in like the particular benefits for your middle tier, and then you have to adjust cost sharing to 60% for bronze, right? If it seems to me very likely that platinum, gold, and silver already have no cost sharing, and that when we're adding cost sharing for this benefit is disproportionately taking it out of the bronze, which means that you either could have disproportionate price increases in bronze, or you could have just moving cost sharing to other services in bronze with, moving it back and forth. And I'm wondering if you did any evaluation of that, since that is typically the lowest priced product and the one with folks who have the least money to buy. I guess the folks who really have the least money get subsidies and are on the silver level. So the bronze tends to be the folks who don't earn enough money, low enough to get a subsidy.
So
I'm just wondering if you did that evaluation. Does that my question make sense?
Right. So around the actuarial value and how the pricing gets shifted to the other benefits, like if the total deductible has to increase or something of that nature in order to remain at the 60% level?
Yes. So if it's like $1.93 PMPM for the individual market, do I need to be worried that it's actually much, much higher in the bronze tier and nowhere else? See what I mean? As opposed to everybody pays $1.93 more.
Right. I don't think that we didn't look at the PMPM increases at that level of detail. Like we rolled it up as individual, on a whole, and small group, et cetera.
Go ahead, Casey.
Yep.
Okay. Pharmacy costs, we did not include those within the out-of-pocket maximum calculation because pharmacy operates differently. So we did apply a 2% reduction to the maximum out-of-pocket to account for some of the pharmacy costs that were not otherwise modeled. So that's just a general assumption. The birth rates that we received within the APCD were not consistent with birth rates that were published by the U.S. Census for the state of Maryland. So we rescaled the APCD data to be consistent with the Maryland Vital Stats Report in 2020 and the US Census. And finally, we have the, in our per member per year calculations, we're assuming enrollees are enrolled for 12 months. So it's just a general assumption there. So, and with the following slides are just, our standard caveats of, the extent that this analysis is going to follow, or reality will follow our analysis to the extent that our assumptions are what happens in the actual market. But for those limitations and considerations above, there's it may vary. Actual experience may vary from what actually happens or what we estimated.
Are there any commissioners who have questions? Comments? We talk about bronze plants more for everyone.
Just a note on this, this came from the Senate Finance Committee. One of the members that sponsored it, told me that he felt as though there were disincentives for having children in Maryland, and he wanted to remove financial pressures on families to have kids. I'm not sure if that bears out in practice, but that was his belief, and the chair at that point felt as though it would likely come back in 2024. So she asked us to do the study.
And look, there's a good public policy reason why we want women to get delivery services when they're delivering.
I don't know if there's a way we can make comment back to the requesting senators, but to impact health outcomes, prenatal care is where a lot of the severe conditions are caught early and maternal morbidity and mortality are reduced. So, if they want to incentivize people to have more deliveries and not pay as much at the time of delivery, I see that. If we want to improve the healthiness, the health of the babies born and the moms who deliver, and decrease some of those morbidity and mortality, which previously we heard do affect Black and Hispanic women more so than white women, to perhaps consider in the future including the prenatal care as well as the delivery care in the $0 copay. Thank you.
Any other questions or comments? With that, I'll take a motion to approve the submission of the Labor and Delivery Services Coverage Cost Sharing SB 784 report.
So moved.
Thank you, Commissioner Gilroy. Do I get a second?
Second.
Thank you, Commissioner Spinner. Any more discussion? Ready to vote? All in favor?
Aye.
Are there any opposed? Thank you, Casey. And
Thank you.
We've made it, Ken, through all 4 of the mandate reports. So you've been waiting patiently. Your moment in the sun. Agenda item number 9, report on the Maryland Commercial Fully Insured Market Alternative Payment Model Arrangements as required by SB 582 HB 1148. Chapter 297 of the 2022 Laws of Maryland requires MHCC to collect data on two-sided incentive arrangements and capitated payments from private payers in Maryland. The data is to be aggregated into a report on or before December 31, 2023, and annually thereafter until December 31, 2032. MHCC shall present this report to the Senate Finance Committee and the House of Government Operations Committee. Kenneth Yates Trotman, Director of the Center for Analysis and Information Systems, and Mary Jo Condon, a Principal Consultant with Friedman Healthcare, MHCC contractor, will present the findings based on 2022 data. Ken and Mary Jo, please proceed.
Thanks very much. Yeah, and commissioners, just to note on the report before Mary Jo start presenting the results, is that this report is a baseline report. This is the first time we have actually reporting on the findings of this report. It's based on 2022 data. As you know, there were no value-based arrangements in 2022, except for when it started in October of 2022. Also, lastly, just want to note that in this report, we would not show any financial results as the results that we got back from carriers were not reasonable as what we expect on a PMPM basis when we look at the total medical spending. That was not consistent in what we expect when we look at variations between carriers. It was more variation, in the report. So we would not show that this time around because we can explain it, and move forward for next time. Now, Mary Jo Condit, a principal consultant with Friedman Healthcare, would now present the findings of the report. Mary Jo?
Thank you so much, Ken, and good afternoon, everyone. All right, let's go ahead to the first slide. So just a little bit more background, sort of building off of what Ken mentioned there. Last year, the Maryland legislature really recognized this national movement towards alternative payment models and value-based care, and identified the need for the commercial market to better align with the Maryland Total Cost of Care model and the Maryland Primary Care Program. And so Chapter 297 requires MHCC to collect data and report on these alternative payment model arrangements. All right, let's go ahead to the next slide. As Ken mentioned, few of these arrangements existed in 2022 because the law didn't even pass until October of 2022. And so the data that was collected in this initial report is really limited. And, as you all know, whenever you have limited data, sometimes the sample size isn't large enough to really get the reliability of results that you'd like to see, for example, on the financial information. So we're not going to show financial information today, in part due to that limited amount of data. However, the report and the data collection really demonstrates, I think, what's possible for future years, and also provides an important baseline for future reporting, particularly around the number of these types of arrangements that were available in the state in 2022. So let's go ahead to the next slide. I just wanted to give you a sense of sort of what's occurring nationally. So currently 9 states, including Maryland, monitor and collect data on value-based payment arrangements, or are beginning to do so. So for example, in California, they're in the middle of developing their process for, putting together those APM data collections. So far, 4 states have published reports on alternative payment model adoption. Those states include Colorado, Delaware, Massachusetts, and Oregon. All right, let's go to the next slide. Wanted to give you just a quick recap of the types of information that MHCC is required to gather data on and report on. So the number and type of value-based arrangements, you're going to see that today. Quality outcomes of value-based arrangements, the number of complaints made regarding value-based arrangements, the cost effectiveness of value-based arrangements, and the impact of two-sided incentive arrangements on fee schedules. Now, during this first year, as we'll talk about more in a little bit, there were no complaints made to the Insurance Administration regarding value-based payment arrangements. So no complaints to report on. The other 3 items here, quality outcomes, the cost effectiveness, and the impact of two-sided incentive arrangements. We'll talk more about this in a bit, but as you can imagine, with only a couple of months of data there, not getting passed till October and the data being based on 2022, we can't really yet look at things like quality outcomes or cost effectiveness. We're going to need a few years of data, or at least a couple of years of data, to be able to look at that. And similarly on the impact of two-sided incentive arrangements. All right, let's go to the next slide. So it's just sort of a very high-level overview of our data collection methodology. As you may be aware, the Healthcare Payments Learning and Action Network is a national organization, it was formed by the Centers for Medicare and Medicaid Services and several national payers. And the purpose of the Healthcare Payments Learning and Action Network, often referred to as HCP LAN, is really to think about how do we categorize the types of alternative payment model arrangements that are out there? How do we group them? How do we measure them? So this is a framework that the HCP LAN created, and it's essentially a risk progression. So category 1, just straight up fee for service. Category 2, there's a link to quality and value. Category 3, you move on to a greater risk for the provider. For example, 3B, there's some risk for downside. You might lose money if things cost more than expected. And then category 4 is population-based payment, almost more like a capitation type payment. We utilize this national framework for the data collection process in Maryland, which is consistent with how several other states have collected APM data. And we also provide technical assistance and worked collaboratively with the payers, first, honestly, to design the data collection and then to improve submissions. All right, let's go to the next slide. So here's a few key findings and summary statistics. So we received data from 3 payers, Aetna, CareFirst, and Cigna. Now, there's a couple of other payers, Kaiser and United Healthcare. They also offer APM arrangements, but those APM arrangements are not linked to quality. There's no impact of quality on how much the provider gets paid. And so we did not include those types of arrangements in this data collection. We were really focused on value-based payments, or payments that also had a link to quality. Humana only offers Medicare Advantage plans, and data on those plans were not collected during this data collection period. I also want to note that CareFirst provided an incomplete submission and only provided information on Category 3 payments. In total, there were 47 APM arrangements. They covered more than 117,000 Maryland residents. 12 of those 47 arrangements were shared savings and downside risk arrangements, which essentially is like a ACO type arrangement where there's a budget for the total care for the patient, and the provider organization needs to either meet that budget or they risk having to pay money back to the payer. Another 19 of the 47 arrangements were episode of care arrangements. And then out of those 12 up there, 8 had that downside risk. As I mentioned before, there were no complaints to the Maryland Insurance Administration. Just to give you a little bit of more detail on those episode of care arrangements, there were colonoscopies, knee replacements, hysterectomies, and pregnancies. We also asked payers to tell us whether or not they had any arrangements focused on pediatrics, and they did not have any of those arrangements in 2022. So let's go to the next slide. I'm not going to read this chart to you. I believe it's been provided to you in the materials, but essentially this gives you an overview by payer of the types of contracts they had and the numbers of members or episodes that occurred under those contracts. Let's go ahead to the next slide. All right. We did not report on quality measures this first year. As I mentioned, not really sufficient data or time to think about the impact of quality, but we did want to share with you the quality measures that have been reviewed with the payers for future data collection. So breast cancer screening, comprehensive diabetes care, follow-up after emergency department visit for mental illness, risk of continued opioid use, acute hospital utilization, and emergency department utilization. And just to note that these are all nationally standardized measures. Let's go on to our next slide. All right, so just sort of recapping a few of the other assessments. As I mentioned a couple of times, there were no complaints from healthcare practitioners regarding value-based payment arrangements in 2022. Because of the short period of time of the law's effectiveness and the limited amount of data, we did not assess the cost effectiveness of the programs during this first year of reporting. We also did not assess the impact of the two-sided incentive arrangements on the fee schedules. Let's go to our next steps. So looking ahead, similar data is going to be collected each year until 2032. We're going to continue to collaborate with the payers to limit the burden of APM data submissions. This was our first year. I think the payers and us had some important lessons learned and can continue to work with them to modify how the data is collected. And I think it's important to note that additional years of data are going to provide a better understanding of the quality of care that's received by patients who participate in these arrangements, the cost effectiveness of the arrangements, and also the impact of two-sided arrangements. So those are ones where the provider is at risk for some of the cost on the value and quality of care. All right, I think that is all that we have for you today. If there's any questions, happy to take questions.
Galbraith?
Thank you for this report. So it looked like the quality measures resembled HEDIS measures. And so I'm just commenting that if you could just take the same data in the same way as NCQA takes it, the burden is so much less.
Great point. And in fact, also great point to note that MHCC will actually be calculating those quality measures internally using the HEDIS specifications. So the current plan is to, and what has occurred under this first cycle, is the payers actually just provide us with a list of the member IDs that are in the APCD that would be engaged in the arrangement. And then that enables MHCC to evaluate performance on quality measures for those members. So taking more of the burden off the payer there and using the nationally standardized specifications.
I'd just like to say I love the framework that you've built. I love also the data collection points. Very interested as we move along what it will actually tell us. I'm not sure if you can speak to this, but I'm going to ask around the MIA and no complaints. It's 2023. Have we received any complaints?
No, we have not received any complaints.
Okay.
Doesn't surprise me though. I don't think most consumers are impacted. They go to the doctor, they pay the cost sharing, they go home. At the end of the year, the doctor may receive an incentive payment from a carrier for managing the population. And you might have a doctor complaining if they don't think they were treated fairly under the program.
We will never.
I don't know, I could be wrong, but did we find any real pathways where we thought that the member would feel motivated to complain one way or the other unless the doctor?
I would hope, because we're measuring.
So I think the intent of the complaints was practitioner complaints, that they were looking for practitioner complaints. Which given that the law will go effect between October of 2022, we're really looking at a 3-month window of program activation. I think we asked the MIA, have you received any complaints through 2023? But maybe Ken can comment on that.
No, they haven't received any comments at all. You know, we have asked twice.
But we're looking at then essentially a 3-month period where there might not actually have been
just standing
one payment cycle, maybe no payment cycles in that 3-month period. So you wouldn't know if you got a bonus or payback.
Many of these are annual.
Okay, so in that 3-month period, they wouldn't know if they were doing good or bad.
So next for the next collection,
it'll be
more mature. So we probably will have more data and more activities as far as complaints.
Sure. Thank you.
Does any of this, if we did a Venn diagram of this and work that's being done at the HSCRC, is there a lot of overlap, no overlap? I mean, I imagine they're gathering some of this data.
I'm not sure they are gathering much of this data at all. They are working with CMMI on a episode-based model that would it be a commercial product would show up here, but that's for the Medicare population only. CareFirst has a parallel program to what's being implemented by Medicare that aligns pretty well in terms of the episodes with the episodes that are being implemented under the Medicare program. But I don't think they're tracking too heavily on the commercial market, but again, I'll yield to Ken.
No, that is yet. We have not have much success in actually having that study. You know, HSCSC is using the private data, but they have not brought that into the model as yet, as far as measures are concerned.
Oh. Not brought you into the model, so are they doing this stuff? They haven't brought us in, or they're not doing?
So of course, you know, commercial payers are included in the total cost of care model, but new value-based programs aimed as these programs are specifically at doctors instead of something that.
Got it. Makes sense.
Do any other commissioners have questions or comments? With that, it's getting late. Thank you, Ken.
Yeah, that vote on it.
I am. I was going to get to the motion next. Thank Ken for his report, though. And do I have a motion to approve the report on the Maryland Commercial Fully Insured Market Alternative Payment Model Arrangements as required by Senate Bill 582, House Bill 1148? Thank you, Commissioner. Do I have a second? Second. Thank you. All in favor?
All right.
Any opposed? Great. Thank you, Ken.
Very much.
Agenda item number 10, MHCC user fee assessment. You all right on time?
Yes.
It's going a little long. I apologize.
But if we can get through, we have two more items. I think they're going to move fairly quickly, but obviously it's up to of the commissioners because more questions certainly welcome. But
We have, this is also a required report. I mean, I think we'll need to address these two items before the end of the year, right? It's not, they aren't items that we could voluntarily defer until January. So my suggestion is we slog through. Let's do it. All right, agenda item 10, MATC user fee assessment. The Maryland's General Assembly passed legislation in the 2001 legislative session effective 2002 that requires the Maryland Healthcare Commission every 4 years to perform a workload study and make recommendations on the appropriate funding level for the commission and user fee allocation among those currently assessed. The report slides are included in your agenda packet. Bridget Zombro, Commission Consultant, will present the highlights of the completed study and answer any questions in advance of the Commission's vote to approve submission of the workload study to the General Assembly. She will also present on minor changes to the corresponding regulations, COMAR 102503, user assessment on payers, hospitals, and nursing homes. Bridget, you have the
Good
floor.
afternoon, Mr. Chairman, members of the commission. You took away my introduction, so I'm just gonna get right into it.
Thank you. I'm told I
Next
legally have to
slide.
read this.
Slide. Senate Bill 786 requires the commission to do two things: remove from statute the industry allocations and incorporate those allocations of what they pay of the budget into regulations, and then to adopt regulations to permit a waiver of the fee to certain healthcare practitioners who earn an average hourly wage that's substantially below that of other healthcare practitioners. Next slide. House Bill 800, which came along later, requires the commission to study the extent to which other healthcare providers not currently subject to our user fee utilize the commission resources and to discuss the feasibility of bringing them into the user fee, and to explore the possibility of the workload distribution might, at least in part, consider future workload. In this report, we went retrospectively. The report is about a year late due to COVID, And if you take the actuals of 3 years and then put 2 years ahead, the fee drives way high. So we didn't want to do that. So we just did 3 years of actual expenditures of the commission. Next slide. How the assessment is calculated. Health insurance payers are assessed based on a ratio of total earned premium collected for health benefit plans by that company over all earned premium for all payers in the state. There are 72 insurance companies right now that currently pay the assessment. Nursing homes and hospitals are assessed exactly alike. 1/2 of the total fee times the ratio of admissions to total admissions in the state for all nursing homes and hospitals, and 1/2 of the total fee times the ratio of gross operating revenue to total gross operating revenues of all nursing homes and hospitals in the state. There currently are 223 nursing homes that we assess and 56 hospitals or specialty hospitals. Out of the the health occupation boards, if their apportionment is 16%, they pay $26 every 2 years because that's their renewal license cycle. And it's just a flat fee across all the health occupation boards. So they all pay the same. Doctors, RNs all pay the same. Next slide, please. The background of the assessment mechanism is current allocations or payers are at 26%, nursing homes are at 19%, hospitals and special hospitals are 39%, and the health occupation boards are at 16%. And as I said, each individual entity's assessment is derived differently by what's in statute. Next slide, please. On the summary of allocation of costs, you'll see that the FY20 actuals are just divided into our current the budget for fiscal year 20. And then they're allocated across all the industries that pay our fee. In the back of your packet, you have a summary of these cost analysis. I'm not going to go into each one of them, but you can see how they were all divided out. This just kind of sums it up. The payer specific cost, for instance, in FY20 was allocated at $3,801,717, which is 26% of our budget. And then so on, so on, so on. So same for 21 actuals, just actual expenditures just divided into the budget. We keep it very simple. Next slide. Next slide. I also want to state, you will see that residual costs, things like telephones and copier rentals and things like just 25% across the board. That's how we do it. Using this methodology, using an average between fiscal year 2020, 21, and 22, the next report will capture 23, 24, 25 in actuals and project out 26 when we bring it back to the commission. Using the methodology that I spoke of earlier, the payers are at 25.4%. Nursing homes are at 19.1%. Hospitals are at 39.8%. And then the health occupation boards are at 15.6%. I'm just going to say I rounded either up or down because we would put the payers at 26% to divide 0.6 amongst all the payers. It would be like $10. So we're going to round either up or down, and that way the assessment apportionment doesn't change for any of the industries. They are currently paying what they will pay for the next 3 years. including the health occupation boards, which are paying $13 for a 1-year license. If they get a 2-year license, it's $26. We also keep track of the renewal cycles for all the boards. So some do by birth date, some do odd years, some do even years. Next slide. The next thing that the law requires us to do is look at the average annual wage of a healthcare practitioner. So back then, when we started doing this, we were trying to think, what is the fair way to do it? So we came up with that the state personnel system guide employees, doctors, nurses, dentists, dental assistants, all of them are currently in the state salary. So that's what we use. So when you hear that the average annual wage is $42,000, that is based solely on the state system and what their classifications are for the health occupation board. So we use that state personnel system and salary guide. There's a range. If I can exclude someone out of our fee, I do. I just do, because, then you have to hear later, like when we brought our ends in, I had 500 phone calls. So we always try to get out to the boards, let them know what's coming, and keep it as low as we can and exclude those that we can. In the following paragraph, they are the health care practitioners that are currently assessed. Next slide. The current average annual wage is $38,629, which is a grade 14 on the state salary scale. The new average annual wage is $42,846, which is a grade 14 on the salary scale. There are no additional exemptions to the fee. So the class of healthcare occupational boards stays the same as well. Next slide.
Can I ask a question about how the exemption works? So is it that all occupational therapist assistants are excluded no matter what they make, or is, okay?
Yes.
You use that average that you just went through to figure out
Yes, I do.
occupational assistants well below that, okay.
Yep, and we look to see what the state would pay an occupational therapist or occupational therapist assistant, and that is below the average annual wage. We do not bring them in.
Okay, but it just goes category by category. You're not asking.
It does,
What they
right.
make in order to get it.
And it's in the back of your package, the salaries for each one.
So the average annual wages are based on what those particular professionals would make working for the state. Is that
Correct.
right? Then the whole thing skews low.
Yes.
Okay.
Yes. Next slide. House Bill 800 also asks us to take a look at additional healthcare providers that can be brought into the fee. So we studied that. Ambulatory surgical facilities, they about 1% of the commission's budget. We studied hospice providers, which are actually less than 1% of our budget. And we also studied the feasibility of bringing in home health agencies, currently at 1% of the budget. So we wouldn't bring them in. 1% split over, I think there's 326 AmSurg facilities. Would be a lot of work for not a lot. Next slide.
The cost of the 500 phone calls may exceed.
You don't even know.
In the back of your pack.
Right? Just a little note here, the commission has a statutory cap. That cap currently is $20 million, and it was raised during the 22 legislative session. Key drivers to increasing the commission's cap are a lot of studies for mandates and the expansion of the APCD, the creation of where the cost during this period of time that was studied, and reporting on hospital and HMO quality and performance and projects pertaining to health information technology or telemedicine. Yes.
You're considering healthcare providers are only those who sit under a board. Is that correct?
Correct. Law reads that they have to be licensed or certified.
Or certified
Or certified.
by the state.
Correct.
And this fee gets built into like their annual due statement.
Pardon me?
This fee gets built into their annual due statement that they would. pay
It
to that
goes,
board.
it goes out when they renew their license. The fee is put right on their license. Next slide. I'm gonna just breeze through these staff recommendations quickly. To release the study that was in your packet, the report to the General Assembly. To approve the proposed regulations. Omar 102502 did not change at all, but they're like a little package, these two regulations, and the one on healthcare practitioners, which is 102503, is just a simple date change. And because we put the time period that those apportionments apply. And we will continue to study the feasibility of assessing other healthcare practitioners or providers who benefit from the services of the commission. That's important too. And during the next study, which will be due to the commission in FY 2026, it takes about a year to do this. To get it into regulations, to break down all the money that was spent, where it went. So the next one will be due to the commission in FY 2026 to be implemented in 2027. And we will look forward at that time to what the projected expenditures will be as well for the commission. That concludes my presentation, and I'm happy to answer any questions.
Are there any commissioners with questions? Or comments? That.
The continue to study the feasibility of assessing other healthcare providers. It's not per se on topic with this. I understand that this has to do with the, assessing the fee with their licensing. But I did not see laboratory science, but they do not fall under a board. But it would be a wonderful thing to research that somewhere they are compared for salary at this current time, especially with the pandemic. Clinical laboratory science has an extreme workforce shortage. And a lot has to do with salary. So if there was a place to have that looked at like we are looking at fees, I just would like to make that known.
Thank you.
So noted. I mean, it is kind of a, what we do because we're using state salaries. That's not really representative of the market in general, but it is, we chose it because we are here. But I would, say, as a couple of people have already observed, that the state salaries probably are not represented these practices generally. I did, Chairman Surgeon, if I could ask Bridget to, so we do get most of the objections from the board licensees. But on a typical license, say for nursing or physicians, what is it? Do you know what the total cost of the license is?
The last time I researched, and it's been a couple years, was I think the physicians board was $680 plus ours.
$6 out of $680.
Yeah, right.
But there are some.
And that's for
people
2
that
years.
Just like,
A 2-year license. And we always make a promise when we get a I say we, I'm sorry, but I used to be here. When we request a cap increase, we try to guarantee that that will not be raised for 5 years. And we have been able to live with that within those parameters, which is wonderful. And I noticed another thing, that the trends are starting to even out with the commission. Now, when you take a look, when we have special studies like you just all heard today, that does raise the budget, so. But we actually try to keep it as low as we can to everyone. And if we have a surplus, we do a reduction. So we won't bill out $1 million, we'll take that money out of surplus and we lower everybody's fee that way. So we definitely try to make it less cumbersome for them to pay, so.
Any other questions or comments?
Just for fun, how long, when's the last time there was a rebate?
A rebate?
happen?
6 years ago, I
Okay,
think,
cool.
6 years
Thank
ago.
All right, do I have a motion to approve the user fee assessment report for submission to the General Assembly? Well, a second? Mr. Gilbert? All in favor? All right. Are there anyone opposed? Last action item. Thank you very much.
We have,
Another.
there's another,
Oh, did I miss one? I apologize. For the regulations.
Yeah.
Yeah, thank you. So I need a motion to approve Comar. Dad, you're supposed to tell me, I almost didn't get.
I know,
your
I'm sorry.
Sorry about that. Do I have a motion to approve Comar 102503 user fee assessment on payers, hospitals, and nursing homes, proposed regulations?
So moved.
Thank you, Commissioner. Second, Commissioner Douglas. Thank you. Any discussion? All in favor? All right. Any opposed? Should just read them all in one motion. Yes.
So just a point of clarification, who is this person? Bridget is a longstanding member of the Healthcare Commission, although she retired some 4 years ago, but she's very familiar with the user fee, having designed it over a period of 2 decades. So we asked her on a number of different projects to come out and help us over this period. She's retired, but she's still a member of the. So thank you.
Ready to go to the Christmas board?
I move she gets to come to the party.
I second. All in favor?
Now
you're stuck.
Agenda item 11, Annual Maryland Trauma Physician Services Fund for fiscal year 2023. The Maryland General Assembly passed legislation effective 2003 that requires the Maryland Healthcare Commission and the Health Services Cost Review Commission to report annually on the status of the Maryland Trauma Physician Services Fund to the General Assembly in accordance with Section 2-1257 of the State Government Act. The report and presentation slides are included in your agenda packet. Richard Proctor, Chief Operating Officer, will present the highlights of the fiscal year 2023 report and answer any questions in advance of the Commission's vote to approve submission report to the General Assembly. Richard, you're up.
Thank you, Mr. Chairman. Good afternoon, Mr. Chairman, members of the commission. I know it's late. I'll be very brief.
Thank you.
I'm really pleased to provide this report to you today. As the chairman noted, the report is required annually in accordance with section 2-1257 of the state government article. An executive summary and background information regarding the fund is provided on page 1 and 2 of the report. Just generally, I want to give a quick general comment. The trauma fund covers the cost of medical care provided by trauma physicians at Maryland's designated trauma center, uncompensated care, Medicaid enrolled patients, trauma-related on-call and standby expenses, and also the trauma equipment grant, which is an every other year grant. My overview will generally follow the slides that were included in your packet. First slide, please. Just a brief background. The fund was established by the Maryland General Assembly in 2003 to aid the Maryland trauma system by reimbursing trauma physicians for uncompensated care losses and by raising the Medicaid payments to 100% of Medicare rate. Formula was established reimbursing trauma centers for related on-call expenses, trauma surgeons, orthopedists, neurosurgeons, and anesthesiologists. The legislation also directed Health Service Cost Review Commission, HSCRC, to allow trauma center hospitals to include trauma-related standby expenses in their approved rates. Statute has been modified several times since its passage in 2003. Next slide, please. This is trauma fund status on a cash flow basis from FY 21 to 23. It's located on page 4, table 2 on page 4 of your report. Trauma Fund's revenue is derived from a $5 surcharge on motor vehicle licenses and renewals. Collections in fiscal year 23 totaled about 12.3 million, which is comparable to FY 22. The fund dispersed about 11.5 million to trauma centers and trauma physicians. Uncompensated care costs totaled about 1.5 million compared to FY 22, which was 1.8. And payment on on-call services totaled 9.2 versus 8.8 in fiscal year 22. The fund balance at the end of fiscal year 23 was $7,483,014 compared to $6,700,833 in the previous year. And the previous year was aided by a $4 million, basically a rebate to the fund by the Budget Reconciliation Act during the legislative session. In fiscal year 2018, the commission lost $8 million to the state to cover certain expenses. So in last year, we were able to get $4 million of those dollars back, resulting in that $6 million surplus. Next slide, please. Table 7, the actual and projected trauma fund spending for fiscal year 21 to 23 is located on page 12 of your report. This is somewhat a repeat of the previous slide, so I won't repeat it. However, I did want to mention a big takeaway is the downward trend in uncompensated care payments and Medicaid reimbursements and the increase on-call year over year that continued in fiscal year 23. As the example I mentioned previously, I would like to just restate real quickly. Uncompensated care was 1.5 compared to 1.8. That represents, in last year, it was 22% of the budget. Now it's 16%. On-call, as I mentioned previously, also increased to 9.2. It's now approximately 80%. So you can see that the pressure is on the on-call side of the equation. Medicaid reimbursements declined this year as well. They're 238,000 versus last year 265,000. Almost all the trauma centers are now collecting maximum on-call allowed by the law. And again, on-call now represents about 4/5 of our budget. And, next slide, please. I just want to mention real quickly outstanding obligations. That's on table 1, page 3. It's $5.2 million at the close for fiscal year 23. On-call, I just want to mention briefly what that means. On-call and standby stipends paid by trauma hospitals from January of the year to June of the year. In this case, January 23 to June 23, but we are reported to the commission after the fiscal year ends. So therefore, they're paid in the subsequent year. So this is an ongoing every year this occurs. So that's what outstanding obligations refer to. And next slide, please. This is expectations for 2020 beyond 2023 and beyond. Actually, it's developing challenges is noted on page 11. There's comments regards to that. I'll just briefly reference a couple of the statements. Just want to restate that on-call representing 4/5 of the total spending for 23 will continue to increase. Trauma centers may continue to inquire about an increase in the $5 surcharge on motor vehicles licenses. Level 2 and 3 trauma centers will receive a larger, I just want to reference this as good news, will receive a larger trauma grant in fiscal year 24 to 25 grant period based on the fiscal year 22 balance, which was 670,000. So this coming grant period, which is 24 to 25, the grant we were appropriated by the legislature $600,000 for this grant period, which will be divided equally between all the applicant centers. That'll result in approximately $85,000 potentially in equipment purchases versus $28,000 in the last grant cycle. Also want to note in the 2023 legislative session, Senate Bill 493 and House Bill 675 passed, which established the Commission to Study Trauma Center funding, which you're familiar with, charged with the responsibility to study and make recommendations on the adequacy of trauma center funding across the state for operating capital and workforce costs. NIMS and this commission jointly staff the commission, and must report its findings and recommendations to the governor and the General Assembly. Commission is in process of finalizing those recommendations as we speak. Additionally, legislature provided a one-time payment in 2023 of $9.5 million. It's added to the budget, to the dedicated purpose account, I should say, within the state reserve fund to aid trauma facilities experiencing financial challenges. The commission must submit a report on the criteria for allocating the funds to the budget committees 45 days prior to any fund transfer. That concludes my remarks, unless there's comments.
Is there ever any opportunity to discuss sources of funding for this beyond motor vehicle? No, so look at who are the people that go into shock trauma, because a lot of them are car accidents, but not all of them. And perhaps allocate some of that expense to the other sources of.
I know this commission to study funding has been addressing related issues in their deliberation.
We'll be happy to share some of the documents that were presented to the Commission on Trauma Funding, which is a short-term commission with a specific purpose to identify what additional trauma needs are not funded and sources of funding. In terms of, I think it would come as a surprise, but it is true that falls are the biggest trigger for trauma visits, and it's a function of the protocols that are in place that get the trauma teams mobilized from the standpoint of EMS onto the hospital.
I am.
Not on you.
So I think someone is on, it's not on mute, but yes, falls are the biggest source, but they don't necessarily trigger, in many cases, all that much cost, but they do trigger the protocol. The trauma teams are assembled, the patients are evaluated, and in many cases, discharged without admission. Traffic accidents are the next biggest, and I believe the next one is construction accidents, and followed by gunshots and piercing injuries. So you're right. Yeah, you're right that other payment sources are needed.
And let's make sure that I'm assuming that motor vehicles then would include motorcycles, but if we see that data, it'd be fun. Interesting to look at.
They play quadruple.
Good.
And factor
I have
on.
no idea.
I have one, so I'm happy to pay $20 to have them there.
Any other questions or comments? With that, take a motion. Do I have a motion to approve the annual Maryland Trauma Physician Services Fund for fiscal year 2023?
So moved.
Commissioner Jensen, do I have a second? Was that a second, Commissioner Boyle? Okay, all in favor? Any opposed? Excellent. We have made it through the action items. And Ben, you can spend as long as you like.
No, I'm not.
telling us what's going to happen.
I'm gonna tell you the big things, which are, we have one very important CON that we believe will come to the January meeting, so don't miss it. It is the coming attraction, and that is the application to replace and relocate the Shore Medical System Hospital at Easton, Maryland.
Was it opposed? Do we have a commissioner who's working on it?
It was not opposed.
Okay.
But they've been trying for more than 10 years to build this. We think the project is ripe for consideration by the commission. Following up on the trauma issues, we'll present the findings from the Trauma Commission to the Healthcare Commission. We'll also describe the methodology for dividing up to 9.5 million in funds that the legislature told MHCC to distribute to trauma centers in financial need. And you'll hear two additional reports. One, I know you're waiting for this one, another mandate study, this one on hearing aids. We'll be ready for January with that. It's a hearing aid mandate for adults. And finally, we have the recommendations on small assisted living facilities that we are ready to present to the commission in January. So I promise you there won't be 10 items, but I can't say how many fewer. Thank you very much for your attention to all these matters today. I know it was a long meeting. Wishing you all the best for the holidays coming up. Hope you all have a restful, peaceful, and safe holiday.
Thank
And
you.
I just
Have a
wanna-
good, healthy.
I want to thank everybody for your engagement and your questions. And I know there were a number of items where you wanted to ask questions about topics that were, tangential, but not strictly the thing. Ben's been noting them down. They're legitimate issues to raise. So if I'm like directing us back to the item, I thought we don't want those to get lost. They're legitimate things to talk about at the same time. So what happens is we'll talk about how do we bring them back for a broader, because we can have a broader discussion as well outside of the context of the report. So I want everybody to know that it's not like you should stop doing that. We'll note them down and see how we can address the commission's concerns and where we can take action. And with that, I will also wish everybody a great holiday and see you in. Do I have a motion to adjourn?
So.
Excellent. I don't think you even have to vote on it.
That's right.
Thank you.